Hello. Good morning to all. I, Dr. J.K. Sharma, the organizing secretary of today's conference, Ipf Medicon 2022, on behalf of Innovative Physician Forum, on behalf of the Royal College of Physicians of Edinburgh, being the international regional advisor for North and Central India, on behalf of Hemwati Nandan Bahuguna Medical Education University, being the visiting professor at there, and Mahatma Gandhi University of Medical Education, Science and Technology, Jaipur, being the visiting professor there, and also the KL University, I welcome you all in the capital city of Delhi, and our faculty from Royal College of Physicians of Edinburgh. I have a special welcome with them. And as we all know, the Innovative Physician Forum, this conference is in association with the Royal College of Physicians of Edinburgh. So, we will start the two-day program. And there are certain points which I want to express and bring to notice of everyone, that please keep your mobile phones either switched off or in the vibration mode. There is a booklet in your bag. You can write your questions on that, and after the session, 1 or 2 talks, the questions will be taken by the speakers. Running tea and coffee is there outside, so there is no tea and coffee break. We have our inauguration starting at 12:20, and the former Chief Justice of India, Justice N.V. Ramana, has kindly consented to be the chief guest. And the guest of honor will be Professor M.L. Swarnkar, who is the Emeritus Chairman of the Mahatma Gandhi University of Medical Sciences, Jaipur. And as we all know, we are all particular about the time. So I request everyone, all speakers, chairpersons, to please stick to their time. So with that, I hand over the proceedings to our scientific chair, Dr. Puneet Khanna. Dr. Puneet, please.
Good morning, ladies and gentlemen. A very warm welcome to all of you for Ipf Medicon 2022. It's a privilege to have all of you here. For the scientific program for the day today, we have sessions on neurology, diabetes, and then we have the inauguration. Simultaneously on Hall B, we have oral presentations and 2 workshops, one on cyber security and the other one on scientific writing. So just to set the ball rolling without wasting much time, the first session of Vertigo, I would like to invite Professor David Mowley for the chair, and also Professor P. N. Ranjan for chairing the session. Sir, please, can we have you on the dais? Dr. Mowley has been a renowned neurosurgeon in UK, in Dundee. He's been at Nine Wells Hospital and Medical School there, and has been a very well-renowned figure in neurosurgery, and we hope to hear him as well. We'll share his expertise. Sir, you can please kindly invite the speakers. Thank you, sir.
Good morning, everybody. Welcome to the early morning session, and thanks for all of you to be here. We start off the first session, the first lecture, and it's my honor and privilege to introduce a good friend. In spite of being a good friend, he's one of the outstanding neurologists of our country, and a gentleman who's been doing extraordinary work on vertigo. He's a senior consultant and neurologist at Udaipur. He is DM Neurology from the PGI Chandigarh and at FRCP Glasgow and FRCP Edinburgh in 2021. Total, he has 21 national, international indexed journals. First to identify and report hypergeographic variant of posterior semicircular canal from India, and the largest series of HCV BPV published from India. He no less than person than Dr. A.K. Watts. May I call upon Dr. Watts to please deliver his talk.
Thank you, chairpersons from India and UK. I straightway, without wasting any other time, will start my topic, central vestibular disorders. Some of you may be amazed to see why it has been changed from central vertigo to the central vestibular disorders. It will be clear in first few slides. Traditionally, vertigo is the sensation of spinning while the body is stationary with respect to the surroundings. In 1995, the American Academy of Otolaryngology, Head, Neck and Surgery defined vertigo as the sensation of motion when no motion is occurring relative to the gravity. This definition is still operational with some changes. The dizziness once upon a time, before 2009, was considered to 4 types: vertigo, illusion of spinning, of movement of self or surroundings; syncope, impending loss of consciousness because of decreased cerebral perfusion; disequilibrium, a sense of imbalance; and ill-defined dizziness was considered to be emotional disorder resulting from hyperventilation, anxiety, depression, or dissociative disorders. This approach is still useful, but now the dizziness and 3 more terms are now very well defined by the Berenice Society by an international consensus. The sensation of self-motion when no self-motion is occurring, there is an addition to it that there is sensation of distorted self-motion during an otherwise normal head movement, and 4 triggered subtypes, namely positional, head motion induced, visually induced, and sound induced, have been identified. The dizziness is now defined as a sensation of disturbed, altered spatial orientation without feeling of false motion. It could be Valsalva-induced or orthostatic or rare triggered forms. 2 other vestibular symptoms, mainly the vestibulo-visual symptoms arising from the vestibular dysfunction or the interaction of the vestibular visual systems, and 5 subtypes, mainly the external vertigo, oscillopsia, visual lag, visual tilt, and movement-induced blur, have been classified, and 4 postural symptoms. These are the symptoms balance related that occur when the patient is uprighted, whether seated, standing, or walking, and the 4 subtypes are directional pulsion that you see in the Wallenberg syndrome due to dorsal medullary infarct, unsteadiness, balance-related near fall, and balance-related fall. Now, with so much of the 4 symptoms, vertigo, dizziness, vestibulo-visual symptoms with 5 subtypes and 4 postural symptoms, it would have been unjustified to just discuss central vertigo myths and realities. So, first myth is clarified here. It is not just central vertigo, it is central vestibular syndromes because of this classification by the international consensus. Prevalence of vertigo and dizziness: 5% of the patients visiting the general practitioner, 10% of the patients visiting the emergency care services. Lifetime prevalence is 17 to 30%. It is the 3rd most common symptom. Acute vertigo and obligor imbalance referred by ambulance or ED. That's what is the system in UK. To a UK-based hyperacute stroke unit from the community was found to have a prevalence of stroke of 60% based on imaging and clinical assessment. And this data is as recent as the November 2022, that is the current month, from the ahead of print, and it was published in the Journal of the Neurological Sciences. So there is need to refer more and more of the acute vestibular syndromes to a hyperacute stroke units, whether it is UK or elsewhere. Anatomy of vestibular system. The peripheral vestibular systems is labyrinth and vestibular nerve, shown by the blue arrows here, while the pink parenthesis points to the vestibular nuclei, brainstem, cerebellum, thalamus, basal ganglia, and cerebrum. They form the central vestibular structures. What does the vestibular system does? It detects the position space, coordinates posture, position of head and neck, coordinates eye movements. Central vestibular disorders, identifying this is critical. 25% of acute vertigo in emergency room is due to infarction in the vertebro-basilateral tree, which can be life-threatening. Earlier you diagnose, better you treat. Severe neurological sequelae can occur with delayed diagnosis. Peripheral versus central vertigo. This is for times immemorial we have been teaching to our undergraduate students as well as postgraduates. The important differences are, number one, hearing and tinnitus. They are common in the central vertigo, peripheral vertigo. They are rare in the central vertigo. Oscillopsia is severe in the central vertigo, while it is mild in the peripheral vertigo. Neurological signs are obviously common in central vertigo and rare in the peripheral vertigo. The nystagmus, I have dedicated few more slides to it, so I'll proceeding to the next slide. The central nystagmus is pure vertical, pure torsional, or periodic alternating, may be multi-direction, disconjugate and dissociated, may change direction with changes in the gaze. The peripheral nystagmus is torsional, horizontal mixed, unidirectional invariably in all cases and is invariably conjugated. The peripheral nystagmus can be suppressed with fixation, but it is none or so in case with the central nystagmus. Alexander law that states that the amplitude of nystagmus increases when the eye moves in the direction of the fast phase is obeyed in peripheral nystagmus, while it is not so in case of the central nystagmus. The central nystagmus is not direction fixed, while the peripheral is. The structures involved are medulla, pontine tegmentum, and cerebellum in the central nystagmus, while it is the labyrinth and vestibular nerve in the peripheral nystagmus. So, with this in background, this is a case of a acute vestibular syndrome showing the right beating nystagmus obeying the Alexander's law. When the patient moves towards the eyes towards the right, the amplitude of the nystagmus increases. However, it remains in the same direction, that is, it is right beating whether the patient is looking to the right or to the left. And the head impulse test, which is an important bedside test in vertigo, was negative on the right side. No catch-up saccade is seen here. While on the left side, you can see a clear-cut catch-up saccade indicating that there you see again. This indicates a hypofunctioning labyrinth in the case of acute vestibular neuritis, or you can better say it's acute unilateral vestibular deficit on the left side. So this is enough. However, there are rare conditions, a plaque demyelinating in the lateral caudal pons in the root entry zone of the 8th cranial nerve can result in identical symptoms and oculomotor signs. So without MRI, it is almost impossible to differentiate between the two conditions. This is a lady with central nystagmus. During the smooth pursuit testing, you can see how choppy and saccadic her eye movements are, and on right lateral gaze, she had a gaze-evoked nystagmus, and again to the left, she has a gaze-evoked nystagmus. This is a central nystagmus. It indicates defective horizontal gaze holding, and the structures involved are nucleus prepositus hypoglossy and medial vestibular nucleus. So this is a central nystagmus. The etiology of the disorders, vascular infections, particularly my fraternity colleagues from UK must be wondering why I have mentioned tuberculosis, neurocystic sarcosis, and malaria. Tuberculomas are common. They can occur anywhere, even in the posterior fossa, and malaria, the most malaria neurological syndrome. Inflammatory, neoplastic, CVJ anomalies, inherited ataxias, including the episodic spinocerebellar ataxias, sporadic ataxia, telangiectasia, metabolic like Wernicke's encephalopathy, chronic alcoholism, alcoholic cerebellar degeneration, neurodegenerative like Parkinson's disease, progressive supranuclear palsy, normal pressure, hydrocephalus. They cause more of the postural imbalance rather than true vertigo. And other important causes are rare tornado epilepsy or epileptic vertigo, traumatic brain injury, and psychogenic and drugs. So clinical clues: acute onset, presence of vascular risk factors, inability to walk unaided, and other neurological signs such as dysarthria, dysphagia, diplopia, visual field defect, blindness, and nasal regurgitation may occur in the acute stroke, which is commonly in the posterior circulation. The diagnosis is by MRI. Acute vestibular syndrome due to vertebrobasilar stroke is best picked up by MRI. Medullary infarcts are notoriously small. They are often missed if you don't instruct the radiologist to look specifically at the medulla. It is usually the thin 1 millimeter cuts of brainstem on diffusion weighted imaging and apparent diffusion coefficient mapping are to be specifically requested. Still, 1 in 5 diffusion weighted MRI will miss the stroke, so 20% of strokes are not picked up even in first 48 hours with the best of the MRI machines all over the globe. This is a dorsal lateral medullary syndrome due to dorsal lateral medullary infarct. The same is seen in the sagittal sections. Isolated vascular vertigo without any other clinical symptoms or oculomotor signs. Does it occur? Once it was taught as I began my career as a neurologist that it is almost impossible. No. Focal infarction selectively involving the structures responsible for isolated vertigo are the nodulus of the cerebellum, lateral caudal pons, flocculus of the cerebellum, vestibular nucleus, and even in the supratentorial region, the dorsal insula. Acute infarct can result in acute vestibular syndrome. So if anyone asks me, do you need a MRI brain in every case of acute vestibular syndrome? I would say a big yes. This is a thing, a lady around 35-year-old came around 10 days back to me. She had acute vestibular syndrome, vomiting, vertigo, some gait ataxia, and she had a tuberculoma in the posterior fossa in the middle cerebellar peduncle. You can see in the axial, coronal, and sagittal images. This you would not say anywhere in the West. None of these literatures in the West say that tuberculoma is a cause of the central vertigo. And this lady, I bring the nystagmus here. If you see the nystagmus, no nystagmus in the primary position, and there is a gaze-evoked nystagmus on gaze to the left. You can see the gaze-evoked nystagmus. So it is a unilateral gaze-evoked nystagmus. We had earlier seen a bilateral gaze-evoked nystagmus. On gaze to the right, you see few jerks, but no definite nystagmus is seen. That jerks are not well sustained. So I would not say that it is a bilateral gaze-evoked nystagmus. It was a unilateral gaze-evoked nystagmus. So only a MRI brain with contrast gave the clue. She was started on anti-tubercular drugs with steroids, and she is expected to follow up with me at 1 month. Clinical clues to the migraine: vertigo is associated with headache, strong history of recurrent headaches, associated visual and sensory auras may be present. Pain usually starts in the occiput. Relief of vertigo occurs with termination of migraine attack. 25% of the migrainaires have associated vertigo. Diagnosis of migraine is by history alone. Episodic vertigo associated with headaches with normal imaging. By the time it reaches a neurologist, the MRI or CT scan is already done. Clinical clues to the MS: usually subacute onset vertigo, presence of focal neurological signs, history of visual loss or blurring is there. Recurrent episodes, that is the clinical and radiological dissemination in time and space. Diagnosis of MRI is craniospinal MRI with fat suppressed orbital cuts. Contrast is mandatory as active plaques are picked up only on the contrast MRI. Visual evoked potential shows prolonged P100 latencies. CSF examination is mandatory to look for the oligoclonal bands which are present in 90% of the patients with multiple sclerosis, and you are able to diagnose a multiple sclerosis with the help of oligoclonal bands with a clinically isolated event, that is the first episode of MS. These are the demyelinating plaques in the brainstem and the cerebellum. Clinical clues to the neoplastic lesions are history of headache, associated vomiting, papilledema, focal signs. The early loss of conjunctival reflex is a valuable sign in these cerebropontine angle tumors. Diagnosis of the neoplastic is by neuroimaging. Always go for a contrast MRI or CT. For paraneoplastic etiology, serum tumor markers and blood paraneoplastic screen is essential. Whole body PET scan may be indicated if there is a strong clinical suspicion. This is a vestibular schwannoma on the right side picked up on the contrast MRI. Clinical clues to the CV junction, short neck and low hairline, that is dysmorphic features with neck pain, burnt fingers indicative of syrinx, atrophy of small muscles of the hand, combination of other focal signs like downbeat nystagmus. Diagnosis is by neuroimaging. MRI is essential of CVJ. Sometimes a CT scan of the CVJ gives a better result in case of atlantoaxial dislocation. This is a Arnold-Chiari malformation showing 15 millimeter descent of the cerebral tonsil with an associated syrinx in the cervical region. Clinical clues to the degenerative ataxia's chronic, relentlessly progressive course in a patient with positive family history. Ataxia rather than vertigo is the chief complaint. Genetic testing and neuroimaging is confirmatory. Diagnosis by neuroimaging showing cerebral atrophy with or without cerebral brainstem atrophy. Genetic testing for spinocerebellar ataxias by commercially available SCA panel by blood PCR costs around 11,000 INR. This is for comparison a normal cerebellum in the sagittal images of the MRI, and this is an atrophied cerebellum. Clinical clues to the Parkinson's disease. Vertigo is a minor complaint. Predominant complaint is tremor, slowness of activities of daily living. Postural impairment, that is loss of postural and writing reflexes. You see in progressive supranuclear palsy, typical fast masked faces. Medication-induced vertigo is an important cause. Around 23% of persistent dizziness in elderly is because of medications. Polypharmacy with 5 or more medications increases the dizziness risk. The important groups are cardiovascular agents like class 1 antiarrhythmics, antihypertensives, diuretics, digoxin, and nitroglycerins. Then endocrine agents, anti-thyroid drug, oral hypoglycemic agents, especially the SGLT2 inhibitors like canagliflozin, hematologic agents, some of them cause the peripheral vertigo like salicylates and aspirin, dipyridamole, infectious agents, neurological agents like memantine, anti-Parkinsonian drugs, anticonvulsants typically at the toxic levels. All antidepressant drugs, whether it is the tricyclics or the newer SSRIs or SNRIs, benzodiazepines and lithium, the miscellaneous like toxic agents like alcohol, hydroxychloroquine causes the peripheral type of ototoxicity, phosphodiesterase inhibitors like sildenafil, tadalafil, vardenafil, anticholinergics, antihistamines, skeletal muscle relaxants like cyclobenzazine, and antispasmodics like oxybutynin. The clinical clues to the epileptic vertigo as an aura, alteration in sensorium, patient goes blank and motionless stare at times. Amnesia for the event, EEG is diagnostic. Neuroimaging is usually normal. It is a very, very rare entity and should not be thought of except unless you are a neurologist. Take home message, my last slide, central vestibular disorders are not uncommon. Migraine is a commonly overlooked cause. Missing a vertebral basilar stroke in a patient with acute vestibular syndrome is unjustified, as it may be fatal if not treated in time. MRI is the preferred neuroimaging modality. Tornado epilepsy should be thought of in episodic unexplained vertigo, and vertical nystagmus is 80% sensitive for the central regions. I finish here. Probably I am in time.
Thank you very much, Dr. Vatz, for a beautiful exposition of central vertigo, and also for your beautiful timing, which is very important. Ladies and gentlemen, I'm thrilled to be here, and I thank Dr. Khanna and Dr. Kapoor for the very kind invitation. I'd like to invite Dr. Avinash Bijlani to speak to us. He's the director of the Madhav Medical Center for ENT and Vertigo in New Delhi, and he's going to speak to us about peripheral vertigo. Thank you, Dr. Bijlani.
Thank you, Chairperson, sir. Thank you, the organizing committee, for giving me this opportunity to share my experience on peripheral vertigo today in this August gathering. So, I'll begin with saying that, you see, the vestibular system, it is such a silent worker. Are we even aware that it's helping us maintain our balance and maintaining the body schema and space? Well, we're just not aware of it, unlike, you can, the sense of hearing gives you hearing, you can smell things and all that. But this is a very silent worker. So it would not be wrong to call it the sixth sense. And that's what I'm here to talk to you about today. And whenever we, at least 20 years back, when I used to get a patient of vertigo in my clinic, I used to feel, well, why is he here with me? Why am I the target? Because sometimes they confuse you so much. It becomes difficult to arrive at a diagnosis, and 20 years back I did not know what to exactly do for them, but prescribe some other labyrinthine sedative. But of course, in the words of W.V. Matthews in 1963, there can be a few physicians who do not experience a slight decline in their spirits when they learn that the patient's complaint is giddiness. And this frequently means that after an exhaustive inquiry, it will still not be entirely clear what is it that the patient feels wrong, and even less so, why he feels it. Well, I think way back in 1963, this was said. We have come a long way since then. And we are beginning to understand the importance of knowing it, because the incidence of vertigo and dizziness is pretty high, as already discussed by Dr. Ajayvat, so I would skip this. And now, when you look at the vestibular system in toto, well, it is definitely the vestibular labyrinth which has the job of the ever so hard-working clerk, giving this information from the periphery along with the visual input and the peripheral proprioceptors to the brainstem. And then there are interactions between the brainstem, cerebellum, and then ultimately the cortex is informed, and it's at the cortical level in the vestibular cortex that the efferents are sent out to the effector organs. So you have over here a simple, small, tiny organ. That is the peripheral vestibular labyrinth. And you can see the 3 semicircular canals and the utricle and the saccule. And this tiny structure is what does the miracle of helping us maintain our balance via vestibular ocular reflex. And ultimately, it is the eye which is at the receiving end, and the extraocular muscles which work ever so hard again to help us stabilize our gaze. And this gaze stabilization helps us maintain our balance and a clear vision during locomotion and brief perturbations of the head. So coming to peripheral disorders now you have the peripheral disorders involving the vestibular nerve and the labyrinth. So over here you have vestibular neuritis, vestibular schwannoma, vestibular paroxysmia, although a rather rare entity, then bilateral vestibulopathy, and amongst the labyrinthine disorders you have again a rare disorder, superior canal dehiscence syndrome, but much more common is Meniere's disease, and the commonest amongst them is the benign paroxysmal positional vertigo, which is kind of the bread and butter of the vertigo specialist. Labyrinthine ischemia, of course, is not so common. So to simplify matters further, what I would like to do is say, let's restrict ourselves to 4 types of common presentations and 6 common disorders. So the 4 types of common presentations are an acute prolonged attack of vertigo, acute vestibular syndrome that is, and amongst these, the peripheral disorder that bothers us is vestibular neuritis, while the central disorder is either a cerebellar or a brainstem infarction, constituting much lesser number of cases. And then recurrent positional vertigo, BPPV, is the prototype. Central positional vertigo, of course, is rarer. Then you have chronic imbalance, where bilateral or unilateral vestibular insufficiency is the commoner one, followed by the central disorders like cerebellar ataxias. Then finally, the 4th way of presentation is recurrent attacks of episodic spontaneous vertigo. Here you have Meniere's disease and vestibular migraine. So from here on, What is more important is the history taking in a patient of vertigo, and if one cannot arrive at a diagnosis after about taking 15 or 20 minutes of history with the patient, I think ultimately the best of investigations possibly may not help us with any of the diagnosis. So what is important is a very careful patient interview focused on the type of vertigo, the duration of the vertiginous event, and frequency and triggers. And a good observation, of course, during the clinical examination for the type of nystagmus that the patient has. So there are 4 key questions again in the history. What is the principal presenting symptom? If it is rotatory, as in a merry-go-round, gives you a clue that you might be dealing with a case of acute vestibular neuritis. If it is postural imbalance, as if in a boat trip, might be dealing with bilateral vestibulopathy, and a lightheadedness with non-specific symptoms could be a phobic postural vertigo. Second question, how long has it been present and how long does it last? So if it lasts from a few seconds to minutes, my diagnosis could be BPPV or a vestibular paroxysmia. Minutes to hours, Meniere's disease, vestibular migraine, transient ischemic attacks. Persistent vertigo lasting many days to a few weeks. I would think of vestibular neuritis or a labyrinthitis. And a postural imbalance lasting for years could be a phobic vertigo, could be a central vestibular vertigo, or a bilateral vestibulopathy. So you see, to summarize this particular point, from the history itself, you can quite often arrive at a presumptive diagnosis, if not more. Is there a significant past history? Well, anything we deal with in medical science that is happening recurrently is much safer than something that has happened all of a sudden and acute. So, has there been any incidence of vertigo or imbalance in the past? Was the patient subjected to a CT or MRI or imaging? Was an audiogram done? So these things are very important. And ultimately, are there any associated symptoms? Headache, hearing loss, dysarthria, diplopia, paresthesia. Barring hearing loss, all the others refer to a central disorder, and then that is what tells me to refer the patient to the neurologist. Anyway, so I will deal a bit in more detail about the very first attack of acute vertigo, that is acute peripheral vestibulopathy. Why? Here, a timely diagnosis is very important in the face of no previous information to rely on. Most important is to separate the benign peripheral conditions from the serious brainstem or cerebellar stroke. Conditions like these, they are pretty life-threatening, and we have published accounts of misdiagnosis leading to the death of the patient. So, you will find static deficits and dynamic deficits when you're dealing with a case of vestibular neuritis. The static deficits are present all the time, even when the patient is stationary, and these are the nystagmus, the ocular tilt reaction, and the lateropulsion, that is, the patient tends to fall over to one side. And this recovers faster over a month, while the dynamic deficits, which present during only head movement, these result in oscillopsia and smeared, blurred images when the patient is trying to look at the surroundings. And these are mostly permanent unless helped by rehabilitation techniques, and these improve by new behaviors so that we are able to conceal the loss. And vestibular neuritis is, by and large, it involves the superior vestibular nerve by virtue of its longer course in the internal auditory meatus, and also there are more spiculae in its canal. Normally, when at rest, the vestibular system is always working. So from the vestibular labyrinth, the canal efferents continue to discharge even in the absence of head rotations, and a discharge increase is referred to as an excitation and a decrease as an invasion. So when we have a vestibular labyrinthitis on one side, in this case, say the left side, we get vertigo because the brain conceives that the other side, which is normal, the head is turning to that side. That means the firing rate, the difference in the firing rate now is what creates vertigo. So we need a simple and quick clinical examination once a patient walks in. When does it begin? Right when the patient has entered your chamber or you have entered the patient's room. See, look at this patient here. She needs to be held when she is walking. Whereas a patient of vestibular neuritis, although with difficulty, can manage to walk on his own. Now here I'm doing an Unterberger's test on this patient. He definitely tends to sway to the left side, the side of his disordered labyrinth, but we're just making sure that somebody is behind him but not actually holding him. And if you are not able to sit up the patient or make him stand, at least make him sit up and look for truncal ataxia. That's a very big sign that this patient is suffering from a cerebellar disorder. I'm an ENT. I'm talking a little about central also because we all need to know when exactly is it required that we can't handle it and we need the intervention of our dear neurologist friends. So head impulse test, Dr. Watts has already described it. I will just rather show you a video on this side. As the head turns to the left, the eyes are supposed to move to the right, and you can see the saccadic corrections the eyes have to make when the eyes go to the right. I'll skip the other video. And well, peripheral versus central nystagmus has already been described in detail. Over here, I would just like to point out that when you get horizontal nystagmus, please do not just fall into the trap of thinking that this is peripheral vertigo. In fact, even in central vertigo, the most common nystagmus we see is horizontal. I think the neurologists here will agree with me. So, well, it definitely increases in intensity once the fixation is removed. So the video on the right, you can see that the intensity of the nystagmus has increased once we have removed the fixation. Well, I'll skip this. Direction changing nystagmus is always central. Vertical nystagmus is always central, whether it is downbeating or upbeating. Well, if you get a skew deviation, as you can see in this picture, that is, there is a vertical misalignment of the two eyes, which is depicted by the cover-uncover test that we do. We are dealing with a posterior fossa lesion. Hearing loss points towards the plus in the hints plus refers to hearing loss. Hearing loss refers to either a labyrinthitis or an ICA infarct involving internal auditory artery. And the MR will show us the infarct in the ICA territory. So when to ask for a neurological referral? Patient above 65 years, pre-existing vascular disease. There's a history of vascular risk factors, smoking, hypertension, diabetes, or a high cholesterol, a normal head impulse test that we discussed just now, or any neurological finding which is not explained by vestibular neuritis. Now moving on quickly to the next type of presentation, that is recurrent positional vertigo. Benign paroxysmal positional vertigo is the most common disorder amongst all vertigo disorders. And the most commonly involved is a posterior semicircular canal, although lateral can happen, not so infrequently. Anterior is pretty rare. And this is characterized by very short spells of severe vertigo, often lasting for just a few seconds, that are experienced only with specific movements of the head. This is a video I would like all to see. This is a case of right-sided posterior canal BPPV. You get an upbeating nystagmus with a torsional component, and the torsional component, the upper pole of the eye, during the torsional component, you can see that it beats towards the affected side. When does it happen? When you subject the patient to, well, we skip this also, I think I'm running short of time, to a Dix-Hallpike test. So in this, what you do is you make the patient lie down with the head turned by about 30 degrees to the affected, to the suspected side, and the neck hands by another 30 degrees. When you make the patient lie down. And we have a very nice Epley maneuver or a Simon maneuver to correct it within minutes. And this is one of the wonders in medical science, I would say, the treatment of BPPV. And we have the supine head roll test for diagnosing horizontal canal BPPV, and so do we have a Guffoni maneuver or some other maneuvers which are available to us to correct this. So whenever we get a case of positional vertigo, please do not go exclusively by the patient's version. Patients always think all havoc has fallen upon them once they develop vertigo. They will not be able to tell you it happens only when they lie down or not. So you must perform positional tests in all patients of recurrent vertigo. And the typical horizontal nystagmus of a lateral canal BPPV can be elicited on a Dix-Hallpike testing also. So do not rely only on one positional test, but do all the tests in all the patients unless you get something. A central vestibular lesion or vestibular nuclei or the caudal cerebellum can also mimic nystagmus that you see in a lateral canal BPPV. Always assess downbeat positional nystagmus neurologically and think of imaging because anterior canal BPPV is rather rare. Vestibular migraine can present as positional vertigo too. And nystagmus pattern here would be most likely of a central type, and it will be persistent and direction changing, and it does not correspond to the canal being tested. Now, recurrent spontaneous vertigo, vestibular migraine has already been taken care of, but I would just like to differentiate it from Meniere's disease. In Meniere's disease, the rotatory vertigo is always seen, where in vestibular migraine, you may encounter dizziness or positional vertigo besides rotational vertigo. Both last minutes to hours, but vestibular migraine can sometimes last up to days. Here the nystagmus beats to the affected side initially in Meniere's disease, and then to the normal side, and a day later to the affected side, but here the nystagmus is of central origin. Fluctuating hearing loss is a hallmark of Meniere's disease. Initially, the lower frequencies involved. Ultimately, later on, all the frequencies get involved. And of course, tinnitus and oral fullness are present. Here in vestibular migraine, it's important to say to have a history of headaches or photophobia and phonophobia. Chronic dizziness is the worst kind of presentation that we ever get, because in all likelihood, I'm not the first person who is going to be seeing the patient. He's going to come to me with a bunch of files and all, and now it becomes a little difficult to see what does he have and what can I do for him or her. So there's a small chart I had made. I'm going to skip because I think I'm falling short of time, I will skip the central part. Well, these patients, mostly if they're suffering from a peripheral vestibular disorder, either they are suffering from a bilateral vestibular failure or from a poorly compensated vestibular disorder. Now, if it is a bilateral vestibular failure, you will have bobbing oscillopsia on walking. The patient becomes worse in the dark. He finds it more difficult to move around and carry on his activities in the dark and on uneven surfaces, and the bilateral head impulse test will be abnormal in these cases. Well, a poorly compensated vestibular disorder, this is usually a residual disorder, dizziness that follows a vestibular event. So to summarize finally, you have a patient with vertigo, one event with acute duration of hours to days, hearing loss is present, think of labyrinthitis. And one single event with acute duration of hours to days, no hearing loss, think of vestibular neuritis. Recurrent events with duration of seconds, positionally provoked, and if the age of the patient suggests so, because BPPV usually bothers the elderly. And then you have recurrent events with duration of minutes to hours or even days, and you have a history of lateralized headache. Please think of vestibular migraine. Finally, Meniere's disease, if you have fluctuating hearing loss, tinnitus, or oral fullness, and think of a bilateral vestibulopathy if the symptoms have been present are those of instability and postural imbalance, and these become worse on walking in the dark. Thank you very much for listening to me patiently. I think I have also finished well within time. Thank you. Thank you. If there are any questions, I think I can
Thank you.
answer.
Thank you very much, Dr. Bijlani, for a beautiful perspective of ENT perspective of peripheral vertigo. Could I invite Dr. Vats to come back to the stage for a question and answer session? We have a few moments for questions. I have one question I would like to ask. One of the syndromes that's always fascinated me as a neurosurgeon is a syndrome where people become acutely vertiginous on hearing loud noises. And the first patient I encountered with this was a burglar alarm technician. And in the UK, burglar alarm technicians tend to spend their time up ladders attending to sirens and alarms on the sides of buildings. So noise-induced vertigo is an occupational hazard. I wonder what your experience of Tullio phenomenon is.
Tullio phenomenon, sir, basically is something that happens as a result of loud noise. And this vertigo is pretty brief, lasts only for a few seconds. And it is rather very difficult to elicit in clinical practice. What we normally do is we subject the patient to an audiometry, and we present loud sounds at about 90 decibels and at a frequency around 2K. And when we do that, and if we get nystagmus or vertigo, we make a diagnosis of a, not necessarily a superior semicircular dehiscence or something, but it can be any perilimb fistula that can give rise to it. It's rather a kind of a non-specific way of making a diagnosis.
And I'd just like to reassure Dr. Vats that all UK medical students are taught about TB in the differential diagnosis of just about everything, but we hardly ever see it. Could I hand over to Dr. Ranjan now, please?
I get your question. What you want to do? About? I just want to ask Dr. Watts one question. You extensively investigate people of central vertigo. There always remain a small percentage of patients of central vertigo without a cause. What do you do with them?
Normally, when you don't find any cause after extensive investigations, especially the MRI and other routine investigations and CSF studies, usually if it is a recurrent vertigo, it turns out to be a vestibular migraine in many cases. One of the other causes I thought, especially a few occasional patients in 20 years of my practice, around 3 or 4 patients I have seen of epileptic vertigo. I gave them anti-epileptic drugs and they responded very well. They had significant discharges and they were not generally localized, they were generalized also discharges. There are some unknown entities which have been described from Korea, that is recurrent vertigo with head shaking nystagmus by J.S. Kim, but I have not come across such an entity. Most often you have been able to make a correct diagnosis of vertigo if you have taken the history properly, because a lot of patients who come to you, कि डॉक्टर साहब मुझे चक्कर आ रहे हैं, yeah, they speak like that, मेरे को चक्कर आ जाते हैं. So they turn out to be an epileptic fit, and many of our general practitioner friends have seen that missing this history and starting patients on vertigo suppressant drugs, rather than asking in detail what happens during and how do you feel like what happens. Then they come out with the history that he falls down. The attendant comes out with the history that patient falls down and he has a uprolling of eyes, tongue bite, and urinary incontinence. That missing that is occurs. With a proper history and a tailored neurological oculomotor examination, it is almost I have not found any patient missing a diagnosis of any patient with vertigo, either central or peripheral.
Thank you.
Please. I wanted to add a bit to what Dr. Watts said. You see, actually, phobic vertigo or functional dizziness is a much underdiagnosed entity. It exists in society, and we have to always keep it in mind. This is not dependent on any kind of test, leave apart MRI or the vestibular, video nystagmography or anything that we do. It is the history which gives you an idea. And then you need to really probe these patients, not only interview the patient, interview the family members also, and then you might come to a diagnosis. And it is pretty easily treatable. And you don't really need to send the patient always to a psychiatrist either. I think we are quite capable of prescribing something like tryptomer to our patients, and that helps. So we should keep that also definitely in mind.
Thank you. I think we have time for one question. We have time for one question from the floor. If you thank you, sir.
Well, I would like to say a wonderful talk and an exhaustive list of drugs in which you have mentioned SGLT2 inhibitors and particularly canagliflozin.
Yes.
So is it a particular drug effect or a class effect? If it is not a class effect, then can we switch on from cana to other SGLT? Will it subside?
I just don't have answer to this question, because this was the first time I went through this literature, and I didn't further dug deep into it.
I have got a question, just one. Benign positional vertigo is one of the most common, and we also see the family members, some of them may be suffering. What is the prevention once you have corrected by the maneuver? What advice you give for the patient so that he himself is able to treat? One. Second is the vestibular migraine. Normally, conventional migraine, we treat by propranolol and antidepressant drug for 6 months. What about vestibular migraine? How you treat and how you prevent?
Avinash, let me answer both questions. Although my talk was on peripheral vertigo, but most of my published literature is on BPPV. So I have taken this onus to answer this. Once you have treated a patient of BPPV with a particular maneuver, first thing is identifying the thing. The posterior canal BPPV is most important. When you diagnose BPPV, you need to know which canal is involved, what is the side, right or left, and then there, especially in the horizontal canal BPPV, whether it is a geotropic variant or the apogeotropic variant. So the most important, the most prevalent posterior semicircular canal BPPV is treated either with the Ipf maneuver. You need to know which is the side that elicits the torsional upbeating nystagmus. The direction of the torsion is towards the right side, then it is the right-sided posterior semicircular canal BPPV. You treat with the right Ipf maneuver. You start from the first disc sulpi position, and then you complete the Ipf maneuver. Or you can treat with the Simon's maneuver. Both are equally effective. Now, you examine the patient after 1 hour. You do a positional test, whether it's a supine roll test or it's a disc sulpi test. There should be elimination of the nystagmus, which was earlier seen, and there should be elimination of vertigo. Preferably, in my practice, I also call the patient at 24 hours and do a positional test, the test which elicited the nystagmus. What happens is that in around 6 to 7% of the cases, there is a canal switch. You had treated posterior canal BPPV, somehow it re-entered from the utriculus into the horizontal semicircular canal, because the openings of the horizontal semicircular canal and posterior canal are very near to each other. So when you do a repeat positional test at 1 hour or 24 hours, you will be surprised to see the change in the nystagmus from the upbeating to the horizontal. So you have to treat it accordingly with the barbecue roll or Buffoni maneuver, as Dr. Bijlani told. Number one. Any other thing, how to prevent it? I have seen that prolonged periods of bed rest, sleeping in one particular lateral recumbent position, or even the supine position for long periods of time. Sometimes this happens with a gallbladder surgery. Your surgeon has told him to sleep in the other left side. So they have been sleeping in left lateral recumbent position for many, many years after the surgery. Or they have a frozen shoulder on one side. So that leads to a BPPV. This is one of the causes. They keep on changing the sleeping positions. That is the one answer.
Right, thank you very much. Thank you very much, Dr. Bijlani, Dr. Vats. In the interest of time, I think we should finish this session now. Thank you very much.
We can have the questions later.
Besides surgical and pharmaceutical treatment of vertigo, is there any role of physiotherapy?
If you don't mind, sir, I think we should have this discussion later. We need to move the session on. Thank you.
Thank you so much, sir. Now I would request the chairpersons to please felicitate our speakers. So just a brief moment. Can we have the mementos for Dr. Ajay Vats? Dr. Ajay Vats. And Dr. Avinash Bijlani. I will request Dr. Upi Sharma sir to please felicitate our chairpersons as well. Dr. David Maule, so please. Dr. P.N. Ranjan is our speaker next, so we'll have your felicitations, sir, once you're a speaker. For the next session now on neurology, I would invite Professor Chitralekha Khati Sharma. She's a renowned professor, a physician in internal medicine in ESI, Gosai Darapur, Delhi. She's from Armed Forces Medical Services of India and served as medical educator for a very long time. And Professor Anshu Rotki, senior neurologist from Gangaram Hospital, New Delhi. And we'll have the session on neurology by Professor P.N. Ranjan and Dr. Kathleen White.
Good morning, all. Special respect to all our seniors, and especially my teacher, General Kalra, who's sitting here. So this is our second session for the day. Electrical disturbances of the head or heart have engaged clinicians at all levels for ever so long, most of the times leading to a battle of wits and will, interspersed by questions and a good dollop of adrenaline. This session promises to be electric, and I'm charged and ready. I will request my co-chair, Dr. Anshu, to introduce our speakers without further delay.
Good morning, everybody. It's a pleasure to invite a very dear colleague and a friend, Dr. P.N. Ranjan, for his lecture on a very favorite topic of his, atrial cardiomyopathy. And Dr. Ranjan has been a senior consultant neurologist at Indraprasth Apollo. He has been the past president of Delhi Neurological Association. He is an EC member of European Stroke Organization, an editorial board of Cerebral Vascular Disease. And the list is really exhaustive. And he has been, he has FRCP from Edinburgh, Glasgow, London. And he's a very, very, really, we have a pleasure to hear to him today. And I will invite Dr. Ranjan to present his talk.
Good morning, everybody. At the very onset, Chairperson, I'm extremely grateful to Dr. O.P. Sharma, who's the man behind this whole conference and who has been my teacher, who really taught me neurology, not taught me neurology, medicine. And I could read this stage, or where I'm standing in front of you, to talk, as Anshu very rightly said, to a topic which is very dear to me, because it is very much neglected and not talked about. And I think it's a novel concept. It's a novel cause of an iatrogenic, cryptogenic stroke. As you know, a large number or group of cryptogenic strokes are somehow later diagnosed to have atrial fibrillation. Now, is that, we don't pick up atrial fibrillation, even if you go ahead and do a Holter for 24 hours, 48 hours, 3 months. There have been studies to say that if you don't do a Holter for as long as 3 months, the pickup is only 7%. So, when I was looking at the literature and my own thoughts, I thought this was a very beautiful concept of picking up patients before they actually develop AF. And I hope I can convince you to say about this new concept of atrial cardiopathy. Atrial cardiopathy is a new cause of stroke. It's not new, but at least I've started understanding it more, and this being a forum of physician, it becomes extremely important. You find severe left atrial enlargement on echocardiography, which is not very difficult. But what we are talking about, and I'm talking about, a PTFV1, that's called the P-wave terminal force in lead V1. And if this PTEFN is more than 5,000 microvolts on ECG. Now, this is the thing for all the physicians sitting here, just to depict the amplitude and the duration and the calculation of the amplitude and the duration. Now, if you look at this picture, this is where you would get the concept of what I'm talking about, of PTFV1. The difference between the amplitude and the duration, and you multiply it, you get the P wave terminal force in V1. Interestingly, current EEG machine do not routinely report PTFV1, and its values show a moderate degree of measurement to measurement variation, thereby limiting its immediate clinical value as a risk factor for vascular brain injury. However, these technical issues are likely to be surmountable and further clinical development of this marker, and in the meantime, PTFV1 may serve as an important research tool in the ongoing quest for better understanding cryptogenic stroke and vascular brain injuries. Many cryptogenic strokes are suspected to be because of occult cardiac embolization. Since PTFV1 has long been established as a marker of left atrial pressure and hypertrophy, association between PTFV1 and brain infarct, independent of document AF, suggests that atrial cardiopathy may cause embolism in the absence of AF. So what I'm trying to say is, you don't have AF, but you are talking about a stage even before actual clinical AF occurs. And why is it important? Which you would all realize that past the age of 60, 65 years, AF is becoming more an important cause of cryptogenic stroke, and I'll give you a new concept of what is called ESES. This is nothing great. We know that the 2D echo criteria for left atrial enlargement, you've got mild, moderate, severe, which is not too great, which can be even measured by any machine. Now, what is a cryptogenic stroke? I'd like to stress on two things: a cryptogenic stroke and an ESES. The trial of ORG 01172 acute stroke treatment defines cryptogenic stroke as a cerebral infarct not attributable to a definite source of cardiac embolization, large vessel atherosclerosis, or small vessel disease, despite extensive cardiac, vascular, hematological, and serological evaluation. Evidence of more than one competing causal or incomplete diagnostic evaluation takes us towards the concept of a cryptogenic stroke. Nearly 65% of patients of cryptogenic stroke have cortical infarcts. On brain imaging, a characteristic typical of cortical infarct, giving the strong circumstantial evidence favoring an embolic pathogenesis of cryptogenic patients. This new entity, I won't call it new anymore, what is called the embolic source of undetermined source, that is called ESES. To describe, ESES is a condition to describe non-lacunar stroke without evidence of ipsilateral extracranial or intracranial large artery stenosis of more than 50%, a major cardioembolic source such as AF or severe left ventricular dysfunction or other specific mechanisms of stroke. ESES, embolic strokes of undetermined source, are operatively defined as non-lacunar brain infarct. They are non-lacunar, they are not lacunar, without substantial proximal arterial stenosis or any major cardioembolic source, and they represent 80 to 90% of cryptogenic ischemic strokes. So that is why the presence of this entity, ESES, becomes important. What are the potential sources of ESAS. Mild or aortic wall, which is cardiogenic, atherogenic, proximal cerebral artery disease, and the last one being the patent foramen ovale. Now, how do you distinguish between cryptogenic versus ESAS? Very simple now, with the new criterion laid down, that cryptogenic stroke never used radiological evidence. But when we talk ESAS, we talk about brain imaging as an important adjuvant in the treatment of ESAS. This is a very beautiful slide, and I think this really covers and is going to cover everything that I've talked and I'm going to talk about. When you talk about cryptogenic strokes, you talk about high-risk cardiac source, cardioembolic stroke, thrombogenic atrial substrate in the absence of atrial fibrillation, embolic source of undetermined etiology. So we are talking about a thrombogenic atrial substrate in the absence of atrial fibrillation, which gives the concept of atrial cardiopathy. Is AF the only necessary substrate for cardioembolism? Absolutely not. Given therapeutic implication, the hypothesis that covert atrial fibrillation is a leading cause of stroke in ESAS is widely accepted and has led to the current practice of performing prolonged cardiac monitoring in these patients. However, 70% of patients do not manifest AF even after 3 years of monitoring. So you keep on monitoring, you find nothing. So you ought to have something more to help these people. And why this concept is becoming more important? Because we are all aware that now with the advent of NOVAX as a very important part in the treatment of atrial fibrillation, we are getting more, at least I'm getting more and more interested in picking up patients of atrial fibrillation. This suggests that AF may not be the only necessary substrate for cardioembolism. What are the possible stroke mechanisms in AF? Usual things. Does AF cause stroke? Does stroke cause AF? Or is AF associated with factors that cause stroke? So I would go by saying, yes, of course, AF causes stroke. Now, if you look at this beautiful slide, atrial cardiopathy is a broadened concept of left atrial thromboembolism beyond atrial fibrillation. You have atrial cardiopathy, atrial fibrillation, thromboembolism. The driving force of thromboembolism is not simply atrial fibrillation, but rather underlying atrial tissue changes with the dysrhythmia leading to both, which worsen with tissue changes, worsen left atrial dysfunction, thereby increasing the risks of cardioembolism. What are the potential mechanisms of atrial cardiopathy? Please look at this nice picture again, which just shows what I've been just talking about, that it is an excitability. It is a dysfunction of the atrium which leads to adiocardiopathy. Recent evidence suggests that left atrial thromboembolism can occur without AF through atrial derangement such as chamber dilatation, fibrosis, endothelial cell dysfunction, and impaired myocyte function. This together was defined as atrial cardiopathy. a term used to describe atrial structure and pathophysiology changes that precede the dysarrhythmia of AF. I hope I made myself clear, and I hope I have been able to convey to you the concept of atrial cardiopathy. Now here is again the same thing to show you that there is cardiac myocytes, fibroblasts, collagen fibers, blood vessels, leukocytes, and all of them lead to atrial cardiomyopathy. Now, various ECG, echocardiographic, and serum markers have been linked to define atrial cardiopathy. But increased P-wave in V1 has been consistently found to be a marker associated with increased left atrial size. So if you have a patient on echocardiography who has left atrial size is big and he has evidence of PTVF1 more than 5,000 microvolt, he falls into the category of atrial cardiopathy. Atrial cardiopathy is only one of the several etiologies that can explain ESS. Patent foramen ovale, aortic atheromas, unstable carotid and intracranial plaques, unrecognized left ventricular thrombus, and undocumented AF. Over a period of time, my unit in the Apollo Hospital, I've been looking at this, and we have done a couple of studies on this also. And this was the first study where we tried to study the role of plasma N-terminal pro-B neurotropic protein in the differential diagnosis of cardioembolic stroke. So we're trying to find out whether in addition to we have any biomarkers for this. We had a total of 108 consecutive patients who presented to our institute with ischemic stroke 72 hours after the onset was studied. They were classified into 5 groups as usual: cardioembolic, large artery, small vessel, and other subtype, and serum NT-proBNP levels were also assessed. Our results showed the NT-proBNP level estimation as a biomarker has been acceptable diagnostic value in distinguishing cardioembolic stroke from other stroke subtypes. So you have a biomarker also to talk about cardioembolic stroke. This was another very nice study where they tried to study the association between left atrial involvement on ECG and vascular brain injury on MRI. This was the cerebrovascular health study, very interesting study, where they showed that the ECG had left atrial abnormality is associated with vascular brain injury even in the absence of documented AF. This is the second study again. We tried to determine the frequency of left atrial enlargement in different stroke subtypes of ischemic stroke based on the TOS classification. We had 109 patients of acute ischemic stroke, and we found that the second highest frequency of left atrial enlargement was found in undermined group patients. That is the possibility of cardiogenic origin of stroke, at least in some of these patients. Further, giving the benefits of anticoagulation and preventing left atrial cardioembolism in patients with AF, further studies may be worthwhile to determine optimal markers of atrial cardiopathy and the effect of anticoagulation therapy in patients with conclusive evidence of atrial cardiopathy with no clear evidence of AF. This is the other study which we have taken. This is a very nice study which is ready for publication. We studied the atrial cardiopathy in various stroke subtypes in acute ischemic stroke, and I can just give you the what you call the results of this, because there's a lot to talk about. And our study did show that every patient of undetermined cause of stroke cryptogenic should be evaluated for cardiopathy. Every patient should have a left atrial size, every patient should have NT-proBNP, and every patient should be measuring his PTA wear. These three parameters will add to our management of atrial cardiopathy as a modifiable risk factor of stroke. This was, of course, an expert review in cardiovascular therapy, which said that atrial cardiopathy may constitute one of the mechanisms in cryptogenic stroke, and patients with evidence of atrial cardiopathy constitute a group of patients in whom clinical trials are warranted to test anticoagulation versus antiplatelets to reduce stroke risk. Summary of key arguments to what I have said. AF is not always temporary to stroke. AF does not show a dose-response relationship with stroke. AF imparts different degree of stroke risk depending on risk factors, and vast majority of AF occurs in setting of abnormal atrial substitute, and left atrial abnormality is associated independently with AF diagnosis. I won't go into all the details, but these are the recent and ongoing trials of NOACs for secondary prevention in ESAS. The Navigate and B-Spec, they were both terminated because they were caused more bleeding. Hence, these two trials were culminating. The theoretical concept of ESAS is based on the fact that most cryptogenic strokes are embolic. Thus, anticoagulation therapy may be more beneficial in these patients. However, neither the Navigate ESAS trial nor the RESECT ESAS trial has confirmed this hypothesis, thinking that anticoagulation may increase the risk of bleeding. This was the European Heart Journal, where apixaban for the treatment of embolic stroke for undetermined source, which is called the ETICUS trial, a randomized trial update of patient characteristic and study life of intermediation. The ETICUS, the preliminary results of ETICUS show that in contrast to the recently published Navigate and RESET trial, ETICUS had more exhibit additional AF predictive factor. Further, mandatory cardiac remote monitoring will elucidate the effect of AF, and preliminary data will be presented to discuss in the context of present literature.
Sir?
Yeah, half a second.
Sure.
Atrial cardiopathy and left atrial dysfunction in patient with EDA, these are the findings from the cardiac trial. So we are going more towards what have we been talking about. Acardia is 2022 said left ventricular dysfunction is uncommon in ACP as defined in Acardia. These findings suggest that patients with ESET, atrial cardiopathy, may represent a separate entity from LV dysfunction. Ladies and gentlemen, I wind up by saying the concept of atrial cardiopathy rather than AF may be better to explain the phenomena of left atrial embolization. Rather than viewing AF as the necessary and sufficient cause of the thromboembolism risk in patients with AF, it would be more helpful to review both AF and thromboembolism as a common manifestation of an underlying atrial cardiopathy. In this formulation, the driving force of thromboembolism is not the dysarrhythmia, but the host of underlying pathological tissue changes which we just talked about. I end by saying no research, no work is possible without a combined effort. And in my hospital, I head the stroke unit. We have an excellent stroke services. We have a stroke unit. And I've been doing this, and I'm sure that I would be able to convince the next study which I will do by using NOVAX in patients and proving that is found to be effective in the treatment of atrial cardiopathy. Thank you very much for a patient hearing.
Thank you, sir. Dr. Anshu, you...
Sorry. So I would request Dr. Kathleen White to present her talk. Dr. Kathleen is an MRCP UK and FRCP. She's a consultant neurologist at Ninwells Hospital, Dundee, UK. And presently, she is a treasurer of the Royal College of Physicians, Edinburgh. She has a number of publications, about 29 scientific manuscripts, 3 paper presentations, 1 book chapter, and in the Sign Guideline, 143 contributor. And she has been awarded the British Medical Journal Veradona Award, the MRCP, she's MRCP UK PACES examiner, and has been a former senior clinical teacher in the University of Dundee. So I invite Dr. Kathleen White to present her talk, and we are very fortunate to hear from her about her work.
Hello everyone, and thank you very much to the faculty and for the college for inviting me to speak to you today. As you heard, I'm a neurologist in NHS Tayside, which is based in Dundee, Scotland, and I do a first seizure new epilepsy clinic, and my conclusions from that are what I'm going to talk to you about today. These are my disclosures. I have done commercial research, mainly on epilepsy. I've received travel grants from a number of pharmaceutical companies, and I've also attended expert panels for UCB and ESI as an advisor. So, these are the areas that I'm going to cover this morning. What is an epileptic seizure actually? But also, more particularly, what other things look like one? And how do you go about investigating it and managing an epileptic seizure? And the other thing is, when do you diagnose epilepsy when somebody's only had 1 stroke? So, what's an epileptic seizure? Well, it's the interruption of normal brain activity by abnormally synchronized neuronal discharges. Now, these are mainly excitatory, as you might imagine with jerking and twitching, but it can be inhibitory, such as you might see in the speech arrest that you can sometimes get in temporal lobe seizures. It's normally brief, lasting a few seconds to a few minutes, but probably the average is 1 to 2 minutes. And why does it matter? Well, it's because it's really common. Globally, about 5 million people are diagnosed with epilepsy each year. And first seizures are even commoner than epilepsy. So first seizures would occur up to 80 people per 100,000 of the population, and the prevalence is 1 in 100 to 200 of the population. And between 4 and 10 people have active epilepsy per 1,000 of the population. And these seizures lead to increased morbidity, particularly injuries, and I suppose tongue biting is the common thing we hear about, but you often come across people who've dislocated shoulders or sustained spinal fractures. And there's also the increased mortality, so that approximately 1 person per 400 of the population will die of their seizures per year. And this is particularly common in young adults, particularly males with refractory epilepsy, where it can rise to 1% of those people with epilepsy. A first seizure also means that you have an increased risk of a further seizure in the 6 months after that seizure of about 50%. And that's why people aren't allowed to drive for 6 months after a first seizure. And because of the driving problems, it can affect people's ability to drive and potentially their livelihood. So, how do we approach the diagnosis of an epileptic seizure? Well, as we've heard before, it's all in the history. From the patient, and they might not remember what happened during it, but they may remember what happened beforehand, and they can tell you how they felt afterwards. But more importantly, you need an eyewitness. And the eyewitness needs to tell you a story with a beginning, a middle, and an end. The before, during, and after. And if the witness doesn't come to the clinic, then it's quite reasonable to ask for a telephone number and to phone them. And during COVID, lockdown was particularly good at having eyewitnesses at home. So that was the only positive thing I can think about lockdown. The other evidence that can help you is that if somebody has a seizure in a public building, sometimes they have closed-circuit television, and you may be able to access that, or the patient may be able to access it for you. And the other thing that we're infrequently asking for is videos from eyewitnesses on their smartphones. So the important features in the history are the onset. What were they doing at the time? Were they in bed? Had they just gone to sleep? Had they just woken up? Or were they standing in the bathroom? Was the environment very hot? Had they had their breakfast or sufficient meals that day or drunk sufficient fluid? Did they have any lightheadedness or pre-syncopal symptoms? And what did they actually look like? Did they go very pale and sweaty? Had they been hyperventilating? Or did they stop breathing and have grunting breathing? Was their posturing of the limbs head or eye turning? And then the event itself. What were the movements like? Did they go stiff symmetrically and then jerk symmetrically? Or did they have posturing or carpopedal spasm or generalized tremulousness, the sort of thing you might see in a rigor or anxiety? And how responsive were they? Is the patient aware of what happened throughout the event, which is the sort of thing you see in a non-epileptic attack? Or were they only aware of people around them, which is sometimes what happens when people have fainted? Afterwards, what were they like? Did they recover quickly, or were they very drowsy? Did they go to sleep? Were they disorientated to place, time, or person? And did they have any neurological deficits, such as aphasia, or they might have weakness down one side, a Todd's paresis? And it may be helpful to ask for a demonstration of the movements. And don't just accept a description, it was a grand mal seizure, because people often pick up jargon, and you might want to actually ask them to demonstrate what the movements were like. And sometimes you may have to demonstrate them yourself and use closed questions such as, well, was it like this or like this? And then from the history, you need to glean other features that might suggest epilepsy. So if it happens to be a young lady who loses control of her hands when she's having her breakfast and either throws her coffee or tips over her cereal bowl, that might suggest the myoclonic jerks that you get in juvenile myoclonic epilepsy. Or you may have olfactory hallucinations, which you might see in temporal lobe seizures, or the strong feelings of unfamiliarity or feelings of over-familiarity in strange places that you get with the déjà vu and jamais vu of temporal lobe seizures, or the rising epigastric aura, which can be very difficult for patients to describe, but sometimes they just motion like this, that something is happening. Then in the history, you want to know about risk factors for seizures, and these are the areas I normally cover. So the antenatal period, febrile convulsions, meningitis, significant head injuries where they've lost consciousness for more than 30 minutes. Is there a family history of epilepsy? And what sort of epilepsy is it in the family? What type of seizures did their relative have? And are they first-degree relatives? Do they drink excess amounts of alcohol? And what was the timing of their drinking to the seizure? And the same for using recreational drugs. And what have they been using? Have they a past history of a previous large stroke? Or have they had brain surgery? And are they on any medications? The list of medication that cause seizures are very long, but synthetic opiates and opiates, antidepressants and antibiotics are common causes of seizures. And obviously people who have epilepsy are much more likely to have seizures if they have infections, and then of course they might be on antibiotics as well. And the differential diagnosis of a seizure includes syncope, convulsive syncope, drug-induced seizures, non-epileptic attacks. These are also called pseudo-seizures or psychogenic non-epileptic attacks, but I think non-epileptic attack is a less pejorative term. Panic attacks with hyperventilation can often be mistaken for epileptic seizures, and sleep phenomena such as periodic limb movements of sleep. I'm going to show you 3 lots of videos. The first is from and I apologise for the age of the videos. The first video is from a study in the 80s of German medical students who first of all were asked to hyperventilate, then they were asked to squat and do a Valsalva manoeuvre before standing up, and then the movements were, then they were videoed fainting. And at the end of that video, there's a video of some Australian football players, which is a full contact sport, showing them having been banged on the head and having concussive seizures. And the relevance of those concussive seizures is that they don't increase the risk of epilepsy. But secondly, I'm going to show you a video of a non-epileptic attack from our video telemetry unit, or our old video telemetry unit in the Dundee Royal Infirmary. And then I'm going to show you a video of a child with periodic limb movements of sleep. So here are the German medical students. And he's been asked to stand up, and he just faints. And then this chap faints, and he has some jerking movements of his limbs, which you can see why somebody who doesn't really know why they might think that that's a seizure. And then this young lady has very prominent myoclonic jerks, which must be quite frightening for observers. And finally, this young man has asymmetric posturing as well as some myoclonic jerks. Now we move on to the video of the Australian football players. So this chap gets whacked in the head, falls down, goes stiff, and jerks a bit. And this chap, slightly more obvious, you'll see the movements that do look like a seizure. We have to remember the brain has a very limited repertoire of complaining about its insults. So, and here is a non-epileptic attack. Oh. So there's chaps reading a newspaper, and you can see the video running, the EEG running, and he just collapses motionless to the side. And that's typical of a non-epileptic attack. And you'll see one of our nurses come in and try to rouse him unsuccessfully. And then she'll lift him up, and you'll see that his eyes are closed. And that's much more common in somebody with a non-epileptic attack. And she's calling his name and asking if he's all right. And he's unresponsive. And those of you that are watching the EEG will have noticed that there's no pathological EEG findings. Oh. I seem to have lost my periodic limb movements video.
Also the feet of the child as the movements.
So there's an arrow. Basically, you need to look at the feet. And these periodic limb movements of sleep movements are actually quite slow. You see a few foot movements there. I think I better move on, actually. So we need to move on because I've just realised my time's getting short. So the investigations of loss of consciousness, the mandatory things at EEG, and you must exclude long QT syndrome as they can present with anoxic seizures. Imaging may not be necessary, and that's if you can predict that the imaging is going to be normal. And that's primarily in children with idiopathic generalised epilepsy or juvenile myoclonic epilepsy, and also in provoked seizures such as concussive seizures or drug-induced or alcohol-related seizures, or if the management's not going to be influenced. If you're going to do imaging, do an MRI, as it's much more sensitive than a CT scan. It will pick up a small number of structural lesions that are missed by CT. It will pick up hippocampal sclerosis in temporal lobe epilepsy, and it's much better at picking up cortical malformations. And when do we do an EEG or an electroencephalogram? The interictal EEG. Well, it's not necessary for the diagnosis of a first seizure or epilepsy, but it may provide support, providing you've got a strong suspicion that this is an epileptic seizure. And I only do them in patients of 30 or under, unless I have a strong suspicion that they have a familial epilepsy. But it is useful if you want to classify the epilepsy into focal or generalised, and obviously it will provide evidence of photosensitivity. So when do we start treatment? Well, a first seizure is not epilepsy unless there's more than a 50% chance of recurrence. So we only treat epilepsy, which is usually more than 2 seizures separated by 24 hours, or if a patient has a single seizure and a very high risk of recurrence because they either have a tumour on their MRI scan or scarring or a previous stroke, or if they have an EEG which shows positive polyspike and wave discharged, or 3 per second spike and wave. And you only treat if the patient's agreeable to it. And we're aiming for seizure freedom, monotherapy, and freedom of side effects. So what drugs do we use? Well, I follow the SIGN guidelines, the Scottish Intercollegiate College guidelines, and I follow the research from the SANAD-1 and the SANAD-2 studies, which was standard versus normal anti-epileptic drugs for epilepsy, newly diagnosed epilepsy. And basically, they found that lamotrigine was superior to carbamazepine for focal epilepsy with less side effects, and that levetiracetam is actually inferior to lamotrigine in focal epilepsy. But in generalised epilepsy, sodium valproate remains the drug of choice in men, although in women there are significant problems. And so in women, if there's not a risk of myoclonic jerks, you tend to use lamotrigine or levetiracetam. And thank you very much for listening to me.
Thank you. Ma'am, please. So the session is open for any questions.
I have a question for Dr. Ranjan. So, would you, in atrial cardiopathy, would you, mild infection, so would you consider 10A inhibitors in the first instance, especially in those where we have, say, PTFV1?
I think I'll... no, I will not really. I think basically, if you have a patient past 65, recurrent strokes, left atrial enlargement, pro-BNP high, PTVF even prolonged, I think he is the patient for anticoagulation. And maybe it is now easier for all of us to monitor anticoagulation because we don't require blood tests. We have got 3 sets of NOACs. You can choose whichever you want. But you have to choose the best. And the best is the one which causes least bleeding, maximum decrease in the stroke rate. And out of the 3, if I can mention, you have apixaban, dabigatran, rivaroxaban. In my own experience, apixaban seems to be the best in all studies which have been available till now. The bleeding risk is there, and you may, anybody in the gathering would ask me that I don't have very specific antidote, especially for apixaban, though we have it for dabigatran. Yeah, you're right in what you're saying, but still the benefit is out of proportion to the risks. The benefit of not having a stroke is really, really good.
Thank you, sir.
Dr. Ranjan, just a brief. All these studies which have been done with all these factor 10A or the apixaban, they have never shown any benefit, in fact, in the studies which have been shown. You showed 4 studies, yeah, but none of them have shown any benefit in So how do you look at that? Like in patients, like you said, the patient has a recurrent stroke, you are suspecting atrial cardiopathy, you have not been able to demonstrate AF, but still you are using the, so you would like to use anticoagulant, although there is no evidence for it. There is no evidence for it. Right now we don't have the evidence. So would you still like to use it? Yeah, sure.
But I think what you're saying is right, that the ESAS and the two studies, Navigate, don't show higher chances of bleeding. I totally agree with you. But now with the cardiac new studies coming up, which are tailored towards looking at the role of NOACs in this entity, believe me, I have started using it because I am, with my experience, quite convinced that number of patients who come to you at stage 1 and I use you subsequently that they do have AF. AF takes time to develop. So we are looking at something prior to that so that we can help our patient. And I have, Anshu may say that it is not scientific as yet, but I think we are gathering more and more experience for the use of NOACs in this subset of patients.
Thank you, sir. We can take one more question. Yes, sir.
Thanks very much for your talks. I wanted to ask Dr. White about, there was a fashion to measure prolactin in patients presenting at the front door of hospitals as a means of trying to determine whether or not they may have had a seizure. Where are we with that now?
I think people are still doing it, and occasionally it's helpful. I think the history is much more important.
Yes, sir.
I think prolactin increase was used some time back to distinguish between a hysterical seizure and a generalized seizure. We have done prolactin in a large number of patients. I don't think that prolactin is a very consistent marker to distinguish seizure from an hysterical seizure.
Dr. White, what is the first drug of choice in a patient with the first onset epilepsy? Do you put all of these patients when you have the first seizure? So when do you put these patients on treatment? Because there's a lot of controversy and there are no clear-cut guidelines. So I think you will be the right person to answer.
We don't treat a first seizure unless they have a risk of epilepsy. So if they had a tumour or they'd had a large stroke or they had an abnormal EEG, then you might treat a first seizure as epilepsy. But generally you want 2 seizures separated by 24 hours to diagnose epilepsy. And then the first drug you would choose for focal epilepsy would be lamotrigine if you have access to it, or carbamazepine. But carbamazepine has more side effects. And for generalized seizures, if you think it's a generalized epilepsy and it's a lady, and there's no risk that she's got myoclonic jerks, again you would go for lamotrigine. But if they had myoclonic jerks, you would go for levetiracetam. But in men, if you think they have generalized epilepsy, sodium valproate is still the drug of choice.
I fully agree with what you're saying. We only have an issue here is that with lamotrigine, the problem is that you need to gradually uptitrate the dose. Yes. So lo and behold, by the time you're gone to the full dose, the patient may have another few more seizures. So typically what we do here is that levetiracetam is a drug of choice for most of us. So that's what I was asking.
Yes, I think in the acute setting, it's not unusual for people to start on levetiracetam, but you do have to realise that it's actually not quite as good a drug in terms of control.
Yeah, I would agree with that.
With that, I will, sir.
Ranjan, you have given very exhaustive talk on cardiopathy. My only comment or suggestion is that we never think of endocrine. If you find a patient who is coming with transient atrial fibrillation, coming occasionally, even after extended Holter modality, you are not finding it. And the so-called idiopathic or whatever you say. One should keep in mind subclinical hyperthyroidism that can give rise to transient atrial fibrillation lasting only for a few seconds. And this is a treatable condition if this should be kept in mind. Thank you.
Thank you, sir. But, sir, we are talking about a very specific entity that is arteriosclerotic atrial fibrillation, sir. So when we are talking about, sir, arteriosclerotic atrial fibrillation, we are thinking of atrial fibrillation as an isolated, recurrent, intermittent phenomena in the elderly. And what I'm talking about in conjunction to that is that, as I just said, that out of all the patients, I was just reading yesterday only, 20% of ESAS patients have atrial fibrillation, which we don't pick up. So that is what this concept which I'm trying to give is to pick up more number of patients who can be benefited from NOVAC therapy.
Thank you, sir. Yes, we will close this session. Thank you to both the speakers. Thank you to my co-chair and to the audience.
I now ask the chairpersons to give the mementos to the speakers. Thank you so much, both the speakers and chairpersons. Time for a group photograph before you leave. Next is a sponsored talk. And our secretary, Professor Sharma, will be giving the deliberation. For this, we have three chairpersons. Dr. Vasant Kumar, sir, please come on the stage. Dr. Sajid Ansari, and General S.P. Kalra, sir. So without much ado, the stage is all yours.
Good morning, colleagues. I think we will straight away go to this important topic, which is going to be dealt by none other than our colleague, Dr. J.K. Sharma, well known to all of you, the man behind the show everywhere, and that includes the present one. So he's going to speak to us on biosimilar insulins, which is very important for us to know, especially in this part of the country where the cost does matter when you have an effective insulin. So it's to you. My co-chairperson will comment after your talk.
I'll just say
one word.
I'll just say a word about Professor J.K. Sharma. As the name of Innovative Physician Forum, he is himself as an innovator. Credit goes to him. This forum came in only 2017, 5 years back. It was born then, and now it has reached to the national level. It is perseverance, persistence, perseverance, and whatever you call add to it goes entirely to Dr. J.K. Sharma. Our credit goes to him, and we should give him a big hand.
Thank you, sir. Thank you very much, sir, for these nice words with blessings. Innovative Physician Forum is not of one person, it is of we all. And I am only a representative. So, as Professor Vasant Kumar sir rightly said, in our India and in our country, the economy is very, very important. So, to consider that, when we consider any drug to be used, we see that it should be potent, it should be effective, there should be minimum side effects, and last but not the least, it should be affordable. Otherwise, the patient will not stick to the treatment, and there is no use. So it's a sponsored talk. This is Biocon's insulin glargine, which is approved in the major markets. In India, it was approved in 2019, but in the US, it was approved by US FDA in 2022. But a very recent development happened in 2021 that it had the interchangeable designation. Means you can interchange this insulin with the other insulins. And for that, regarding the data package, I will go through certain studies. So the first is the global PKPD phase 1 study, Bezalog process 5, Bezalog versus the European Lentus versus the US Lentus, and how it got the interchangeable designation, we'll go to that. Then the INSTRIDE 1 phase 3 trial of type 1 diabetic patients, and the INSTRIDE 2 phase 3 trial of type 2 diabetic patients, and then the INSTRIDE 3, that is the phase 3 trial of type 1 diabetic patients, and that is also the switch study. Now the Biocon's insulin glargine, the global trials, they have happened in many countries. This is the clinical trials, 7 clinical trials where 1,915 patients in 20 countries were included in the various trials. So coming to the first trial, that is the biosimilar insulin glargine global phase 1 PKPD in type 1 diabetic patients. And this was presented, the e-poster was presented in the American Diabetic Association's San Diego conference in June 2017. And the comparative PKPD of a proposed biosimilar insulin glargine and reference insulin glargine in patients with type 1 diabetes. The study design was the PKPD bioequivalence measurement of biosimilar glargine with US reference glargine and European reference glargine. 114 type 1 diabetic patients, study design, it was a single center, randomized, double-blind, single-dose, 3-way crossover, hyperinsulinemic euglycemic clamp study, and the patients received a single subcutaneous injection of 0.4 units per kg of each trial drug. We welcome Professor M.L. Swarnkar, our guest of honor. Sir, welcome. Now the study design, there were randomization screening, and within the first 28 days, there was visit 2, which was the first claim was put, and at visit 3, the second claim was put after the 28 days, and the third claim was put as visit 4, and within 10 days, there was the visit 5 and the follow-up. When we look at this, the mean serum insulin concentration profiles of 3 insulin glargine preparations were similar, which we can see here with this overlapping graph. And the plasma M1 profile also, the mean plasma M1 concentration profile of the 3 insulin glargine preparations, that was also similar. Now the GIR profiles were nearly superimposable and they were comparable. So to conclude the first study, the bioequivalence of biosimilar insulin glargine, the US insulin glargine and the European insulin glargine was demonstrated in patients with type 1 diabetes for both primary pharmacokinetic and pharmacodynamic endpoints. And the biosimilar IG, US IG and the EU IG were generally well tolerated and no significant safety issues were emerged. Now coming to the INSTRIDE 1, this was a non-inferiority study to compare the efficacy and safety of Biocon's insulin glargine with reference insulin glargine in type 1 diabetic patients. And this again, the e-poster was presented in San Diego in American Diabetic Association's annual meeting in June 2017 to look for the efficacy and safety in type 1 diabetic patients. The objective was to determine whether Biocon glargine once daily is non-inferior to reference insulin glargine once daily when administered in combination with mealtime insulin Lispro in patients with type 1 diabetes. Multi-center, open-label, randomized, parallel group, comparative phase 3 study. The sample size was little larger, 558 type 1 diabetic patients where the HbA1c was 9.5 around at screening, and 18 to 65 years of age patients were included. They were treated with once daily insulin glargine for at least 3 months. Again, screening for 4 weeks, run in next 6 weeks, and then in the 2 arms, Biocon's insulin on one side and reference insulin glargine on the other side, and the follow-up for 4 weeks. Primary endpoints were change in HbA1c from baseline to week 24. Non-inferiority margins were decided by the upper limit of two-sided 95% confidence interval difference in mean from baseline to endpoint for HbA1c was no greater than 0.4% at week 24. Secondary endpoints of efficacy were HbA1c change from the initial administration to week 52, change in fasting plasma glucose, and change in insulin dose with the self-monitoring of the blood glucose. And the secondary endpoints regarding the safety, it was looked for hypoglycemia, other adverse events and adverse reactions, and the immunogenicity, that is the anti-drug antibodies. Again, we can see that the HbA1c stabilized at all time points from the baseline, and the actual fasting plasma glucose by visit and treatment. So the conclusion for this study was no significantly significant difference in the actual HbA1c profile between the treatment groups, and both basal and bolus insulin dose levels did not differ between groups, and rate of hypoglycemia and other adverse events were comparable between the two groups. So again, this Biocon's insulin glargine has similar efficacy, safety, immunogenicity as the reference insulin glargine in type 1 diabetic patients. The INSTRIDE 2 trial, which showed the non-inferiority study to compare the efficacy safety of this insulin with reference glargine in type 2 diabetic patients. And again, the study was designed to determine whether this was non-inferior, and multi-center, open label, again equal number of patients, around 560. They were again screened, Biocon's insulin glargine on one arm for 24 weeks and reference insulin glargine for 24 weeks, equal number practically, and follow-up for 4 weeks. The primary endpoint and the change in HbA1c again from baseline to week 24, non-inferiority margins, upper limit of the two-sided 95% CI for difference in mean change from baseline to endpoint was no greater than 0.4%. Secondary endpoint, efficacy and safety. So this was in type 2 diabetic patients, and again we can see that mean actual HbA1c over time was equal. Both the graphs are overlapping to each other. And if you look here, the LS mean difference between the groups is 0.06%, and non-inferiority margin upper bound of 95% confidence interval for mean change was 0.4%. So mean actual glargine dose over the time, if you look here, then this is the biosimilar insulin glargine, the lower one, and the upper one is the reference insulin glargine, and this you can see the actual daily basal doses. So the conclusion for this study was the mean change in HbA1c was similar in patients with type 2 diabetes, both the groups. Results demonstrate that insulin glargine is non-inferior to reference insulin glargine in patients with type 2 diabetic patients. Change in fasting plasma glucose from baseline to week 24 were similar in both groups. Insulin glargine dose level did not differ between groups, and rate of hypoglycemia and other adverse effects were comparable between the two groups. So this again has similar efficacy, safety, immunogenicity as the reference insulin glargine. Now coming to the INSTRIDE 3, which is to assess the efficacy, the insulin dose, safety and immunogenicity when people with type 1 diabetes switched between Biocon's insulin glargine and reference insulin glargine. So this is the switch study, and an overview of this INSTRIDE 3 study, the first switch, then this is the switching sequence, which we can see that in 12 weeks, period 1, again 12 weeks, period 2, and the period 3 after 12 weeks. So it's total 36 weeks, and it is a robustly designed with adequate switch periods, which we can see here. So if you look at the results, the change in HbA1c from baseline to week 36 with Biocon's insulin glargine switching sequence was equivalent to the reference insulin glargine. And overall incidence of any hypoglycemic event, which is a very important factor in all diabetic patients, were comparable between the two sequences, and no severe hypoglycemic event occurred at any time point in the study. So anytime hypoglycemia events were comparable in both the sequence throughout the study. When we come to the immunogenicity data, equivalent efficacy, safety, and immunogenicity demonstrating that patients taking reference insulin glargine can safely switch to Biocon's insulin glargine. Now, assessment of the immunogenicity in INSTIDE 1 and INSTIDE 2 studies, this was again the e-poster which was presented in 2007 in the American Diabetic Association's annual conference, and no statistically significant changes from baseline in cross-reactive ADA % binding between treatment group at any point in time in either of these studies. And the proportion of the patients with total cross-reactive insulin antibody response who met the criteria for this or total ADA positive response were similar in both the groups at all points of the point, and this demonstrates the antigenicity. So to conclude this immunogenicity assessment in INSTIDE 1 and INSTIDE 2, comparable immunogenicity profile in two groups. Majority of patients with type 2 diabetes were negative for total ADA, and majority of patients with type 1 diabetes were positive for total ADA, consistent with previous studies indicating a prevalence of insulin antibodies in type 1 diabetic patients. So proportion of patients who tested positive for anti-SCP antibodies were similar between the treatment group. The FDA news release, which was on July 28, 2021, approves first interchangeable biosimilar insulin product for treatment of diabetes, and availability of product will help increase access and potentially lower the cost of insulin for people of diabetes, not only in India, but across the globe. And US FDA approved the first interchangeable biosimilar insulin product indicated to improve glycemic control in adults and pediatric patients with type 1 diabetes and in adults with type 2 diabetes. And approval of this interchangeable glargine can provide patients with additional safe, high quality and potentially cost-effective options for treating diabetes, and an interchangeable biosimilar product may be substituted for the reference product without the intervention of the prescriber. Now, if you look at the FDA and US Congress on one side and the WHO, where do we stand? Biological product may be substituted for the reference without the intervention of the healthcare provider, and WHO says the interchangeability should be based on appropriate clinical data and potential safety issues should be considered. So, recommendation for switching to a biosimilar insulin, the Diabetes UK, they say people with diabetes choose to switch to a biosimilar insulin, they should be encouraged. Diabetes UK, this is the position statement of Diabetes UK. Now, what is the health impact? What are the challenges and what is the eased out with the biosimilars? The challenges are reserved for patients who afford the costly medications. Now we move towards the affordable and the optimal therapy. Late insulinization because of the cost, but if we go for timely insulinization, if we control the HbA1c early, the micro and macrovascular complication rate will definitely come down. So this reduces the morbidity and the mortality. So rising economic burden, insurers, government, NGOs, and now coming to the healthcare cost savings. So this is a very important aspect of this. And it is about 16 to 48% economical than the reference insulin glargine. Now, to summarize this, the world first interchangeable biosimilar insulin made in India, for India, and now not for India, now for across the globe, and the world, Atmanirbhar Bharat, self-alignment and patients benefit, high quality insulins, affordable price, improved adherence. And for we healthcare providers, option to provide quality insulin to their patients, reduced economical burden, and better compliance to therapy. With that, I finish my talk and I thank you all. Thank you very much.
Very well covered topic and very pertinent for us. And we are the innovator in that regard. We are the one who first approved it and is followed lately by the Westerners. And final approval by the US came only now in 2022. And the speaker has done justice to his talk. The question answer will be after the second.
Thank you, sir. Now the next talk is by our prolific speaker, Dr. Aparna Jaswal.
Dr. Padma Gulati to please come to chair this session. Thank you so much.
So we have Dr. Aparna Jaiswal, who's a director in Department of Cardiology at Fortis, Okhla. She has a glorious academic career with gold medals through her MBBS and cardiology. She is certified by IBHRE USA as certified cardiac device specialist. She is an arrhythmia specialist also. Over to Dr. Aparna. Yeah.
At the very outset, I would like to thank IPF and Dr. J.K. Sharma, Dr. Manchanda for giving me this opportunity to be here this morning. And in the next couple of minutes, hi Dr. Meenu. In the next couple of minutes, I will take you through what do we mean by something which is very common and that you see in your emergency room. That's the narrow complex tachycardias. That is something which all of us have seen at one point in time in our practices. So management of a patient with narrow complex tachycardia is what I have been entrusted with in the next couple of minutes. So this is the classic ECG, what you see of a narrow complex tachycardia. The fact that the rate is more than 100 makes it tachycardia. The fact that the QRS is less than 120 milliseconds makes it a narrow complex tachycardia. Whenever you see a narrow complex tachycardia, what must come to your mind that where is this rhythm originating from? Is this rhythm originating from the atria, from the AV node, junction, or below that? Remember, whenever you see a narrow complex tachycardia, it implies that the rhythm is originating from either the bundle of His and above, which implies either the AV junction area or the atria. If the rhythm is originating below the bundle of His, it will be a wide complex tachycardia. You can even have a tachycardia originating from above but becoming wide if the patient has an inherent bundle branch block. But typically, when you see a narrow complex tachycardia, always keep it in your mind that the tachycardia is originating either from the atria or from the AV junctional area. So that makes it simple to understand that that's where the rhythm is originating from. And this is how the electrical conduction system conveys the impulse from the sinus node to the atria, to the AV junctional area, then the bundle branches, and there is arborization of the bundles, and there is near simultaneous contraction of both the ventricles. So that is where it is arising from. And what brings us to the most pertinent question, is every narrow complex tachycardia to be called a PSVT? Because often we see ECGs, we are all confused. Shall I call it a PAT, a PSVT? Shall I call it an SVT? So you should remember that PSVT implies paroxysmal supraventricular tachycardia. It is to be used only when you are dealing with node-dependent tachycardias, which are AVNRT, AVRT and atrial tachycardias in a minority. Remember, when you have anything like junctional tachycardia, atrial flutter, you do not call them PSVT. Remember, the umbrella of supraventricular tachycardia is very large. It is intuitive to understand atrial fibrillation arises from the atria, but it is not supraventricular tachycardia. According to the ACC European guidelines, it is separate entity. Reason? It in itself is such a big and a complex entity, it cannot be covered under the umbrella of supraventricular tachycardia. So whenever you talk of supraventricular tachycardia, all of them are there, but when you say paroxysmal supraventricular tachycardia, it is AVNRT, AVRT, they being node-dependent tachycardias, and an atrial tachycardia. So how do we deal with them and manage them? So these are the 4 pictures of the tachycardias I just mentioned to you. Remember that when you're dealing with any of them, what is it that clinches the diagnosis as to what am I dealing with? It is the P wave. It is the atrial contraction, which will tell you, am I dealing with a PSVT or am I dealing with an atrial tachycardia? I will show you in the animations and some ECGs as we go along as to how do we identify. But in your clinic, if a patient comes with something like this is one of our patients who had recurrent PSVTs, he knew exactly how to terminate. He also had an aortic valve replacement done in the past. He was very reluctant for any procedures. He said, I have repeated episodes of PSVT. I know how to terminate my tachycardia. He came to my office in our clinic. We said, and he said, I'm having the tachycardia right now. We said, okay. We put him on the monitor and see what we saw. We put him on the monitor and we saw that he was having a tachycardia. He said, doctor, don't panic. I know how to stop it. See what he does. We sought his permission to show it to all of you. So he said, this is exactly what I do. I touch my carotid. He didn't know the carotid. He said, I touch my neck and look what happens to my tachycardia. He terminated his tachycardia by doing what we call carotid sinus massage. A word of caution, when you do carotid sinus massage as clinicians, you must auscultate for a carotid bruit. Before that, do not. So this guy knew it. Remember, if you have a tachycardia which is amenable to termination by a vagal maneuver, it implies you're dealing with a node-dependent tachycardia. That means any vagal maneuver makes the node slow. As soon as the AV node becomes slow, the tachycardia terminates. That's what you want to discern. So whenever you see a narrow complex tachycardia, there is a quick flow chart which you should not get complicated about. This looks like a busy slide. It's from the European guidelines. But what is most important that you must remember to identify is try to look for P waves. The presence of a P wave on an ECG helps you clinch your diagnosis as to what am I dealing with. When you see a narrow complex tachycardia, what is it that you see on a P wave? You look at the relationship of the P and the R. That I will just show you. You look at this. This is a P wave and this is the R. You want to identify, is this P wave hanging to the preceding R, or is it hanging to the succeeding R? If this P wave is hanging more with the preceding R, it is called a short RP tachycardia. If the P wave is closer to the succeeding R, it is called a long RP tachycardia. It's very simple. Relationship of R to P. So if the P is hanging with preceding, it is called short RP. If it is preceding with the succeeding R, it is called long RP. This is the fundamental point that you should remember when you want to identify tachycardias and treat them. Another example on the ECG, this is implying. So you have an ECG, look at this, this is R, P, it is so short, it is hanging with the preceding one. This is what is called short RP tachycardia. Look at this, the P wave is hanging with the preceding R, it is called short RP tachycardias. In all our practices, 80 to 90% of supraventricular tachycardias are like this. So it's a simple thing which I will just take you through some examples. Again, remember, when you're dealing with a supraventricular tachycardia, just look at the relationship of the P and R, whether it is a short RP or a long RP. Not going into intricate nuances of it, but keeping it basic and simple, This is a typical ECG of a narrow complex tachycardia, and you can see this is a P wave which is closely related to the preceding R. You have a short RP tachycardia. When it is so close, you know you're dealing with something called AV nodal reentrant tachycardia. Also, you should know why is it so close. In an AV nodal reentrant tachycardia, the tachycardia circuit is within the AV node. So there is near simultaneous activation of the ventricle and the atrium. Because they are activating simultaneously, it results in the both R and P being very close to each other, as you can see in this animation. Everything is happening within the AV node. The activation of the atria and the ventricle is taking place parallel. Both of them activate together. Short RP tachycardia with very close P to R. Whenever you see this in your emergency room, the management, I showed you a vagal maneuver, which can be a simple carotid sinus massage, which can be a Valsalva maneuver, which can be face immersion in ice cold water. If nothing works, yes, the answer is adenosine. Adenosine is one of the safest drugs in wide complex tachycardias. The T half of adenosine is 9 seconds. So you're very safe. Never use in wide complex. In narrow complex, use it. It blocks the AV node, terminates the tachycardia, and you know it that you're dealing with an AVNRT. For chronic therapy, you need to bring the patient to the EP lab. The success of a procedure, what we call catheter ablation, in the EP lab is to the tune of 97 to 98% when your patient has AVNRT. How do we do an ablation? Typically is we go through the femoral vein, we access the femoral vein, we enter the IVC. After the IVC, we enter from the IVC, we enter the right atrium. From the right atrium, we understand where do we wish to go. Should we enter the left atrium? We go transeptal and enter the left atrium for a tachycardia which is arising from the left atrium. For other tachycardias, we work on the right side of the heart. So this is another young gentleman who comes repeatedly to the emergency room with no structural heart disease. Again, what do you see? There is tachycardia. It is narrow complex. Look at the P wave. This is the P wave which is glaring at us. It is just behind the preceding R. So I told you, if the P hangs with the preceding R, it is a short RP tachycardia. It tells me it probably is a node-dependent tachycardia. It can either be an AVNRT or it can be because of an accessory pathway. So this is the P. I know it is probably an accessory pathway. What happens in an accessory pathway is exactly this. The electrical impulse goes down the normal conduction system which I showed you, but goes up the accessory pathway. So you can see the circuit here is not parallel, but first it goes down to the ventricle and then it comes back to the atrium. That much time is conveyed. Hence, it is a short RP tachycardia, ventricle, atrium, but it is not parallel. It is in series, the ventricle and then comes back to the atrium. It continues to remain a short RP tachycardia, but it is unlike AVNRT, the P is a little behind. The P is a little behind the R. It is not that you have to know it, but it's a nice idea. Another clincher is the electrical alternance. What is the meaning of electrical alternance is this. Every other QRS is large, tall, short, tall, short. When you see electrical alternance on an ECG, you should think, am I dealing with an accessory pathway? A young 20-year-old tachycardia with ECG changes of STT depression, don't worry. Patient does not have coronary artery disease. It is just the STT has been pulled down because of the P wave. So when you see these are soft signs on an ECG which tell us that I'm probably dealing with a node-dependent tachycardia with an accessory pathway. Similarly here, it is tachycardia, it is narrow complex, but look at the STT. When I see this ECG, I already tell my fellows this is likely to be an accessory pathway because there is so much STT changes taking place. The answer to this patient is also in the emergency room, vagal maneuvers and adenosine. If these work, you know you have a node-dependent tachycardia. However, you want to make the patient asymptomatic, you need to take this patient to the EP lab and do what we call radiofrequency ablation. The success of radiofrequency ablation is to the tune of 97 to 98%. In a minority, you may not be able to ablate. This is how we position the catheter across the aortic valve, and this is under the mitral valve for ablation of left lateral accessory pathways, which are the most common accessory pathways. And this is an animation telling you how we ablate. We could either do radiofrequency energy by heat energy, or we could use cold energy and what we call cryoablation. So basically we heat the tissue or cool the tissue so much that we kill that tissue. And of course, when you deal with tachycardia is another example. There is heart rate is more than 100, it is narrow. Look for the P waves, look here carefully. You can see the P waves here. I told you, look at the P waves here. Clearly the P wave is hanging with the succeeding R rather than the preceding R. So it is a long RP tachycardia. Whenever you're dealing with a long RP tachycardia, the first thing you should come, am I dealing with an atrial tachycardia? What is the meaning of an atrial tachycardia? The focus is within the atrium. This is the origin, and it is going down the AV node. The circuit is not node dependent. So in this case, adenosine may not help terminate the tachycardia. In this case, if the patient has hemodynamic compromise, you do cardioversion. Otherwise, you can attempt giving verapamil, dilsem or beta blockers, which will reduce the rate. If you want to treat the patient of the problem, bring the patient to the EP lab, and I'm showing you one of the cases that we did and terminated the atrial tachycardia by utilization of three-dimensional mapping, where we produce the model of the chamber and we find the earliest site of activation, go there and ablate the tachycardia. And of course, atrial flutter. We have been reading from our MBBS days that an atrial flutter gives a typical ECG pattern, what we call sawtooth pattern. See this, there is a sawtooth pattern. While you get this sawtooth pattern, refer back here. In an atrial flutter, it is a macro reentrant circuit. At no point in time are the atria having electrical quiescence. They are all the time active. Because they are all the time being stimulated electrically, it is apparent on an ECG by a sawtooth pattern. There is always electrical activity. There is never a point where the atria are settled. Because the atria are always working, they get tired, as does the ventricle. So if you want to treat an atrial flutter, you should know that the success of atrial flutter is flutter ablation. The success of flutter ablation is very high. If we take the patient to the EP lab, this is a propagation map which we have made in our lab of atrial flutter. We go here, we make a line at the cavo-tricuspid isthmus. The success of flutter ablation is to the tune of 90 to 95%, which is extremely rewarding. And of course, I will not be justifying unless I speak about focal junctional tachycardia. It's important to remember that they're very uncommon in adults. It is more common in the pediatric population. It is also common post-operatively in a pediatric population who has undergone congenital heart disease surgery. The treatment in this is also beta blockers, dilsem or verapamil. You should remember that. And as I said, there are certain ECG characteristics of these tachycardias. Most important to remember is try to identify the relationship of the P wave with the QRS. That will help you align where you are. With this, I'd like to conclude. Thank you so much. Morning, sir. How are you, sir? Long time.
Thank you, Dr. Parna, for such a fantastic presentation. Do we have any questions from the audience?
Well, I would like to compliment Aparna for a wonderful talk. And I remember as long as 1997, when during the sheep study, they mentioned that atrial fibrillation leading to stroke, multiple strokes, and we used to be always confused which one to treat, which one not to treat, because either you try to protect a stroke or you try to protect hemorrhage. But ever since the new modality has come, and especially after cardiac mapping, when you are exactly able to pinpoint the place where you do RF, is a fantastic thing. As a matter of fact, you are going to prevent strokes in future. Thank you.
Narrow QRS tachycardia. For a physician to suspect the patient has got narrow VT, ventricular tachycardia, what are the salient points you will suggest they should know that it is VT, not AT?
So I think what sir wants me to identify and delineate the distinction between a ventricular tachycardia and a supraventricular tachycardia. So whenever you see a patient with tachycardia, a heart rate of more than 100 beats a minute, and the first thing you do is an ECG. You've never seen the patient before. So when the patient comes to your emergency room, if you see the patient has a narrow complex tachycardia, means the QRS is less than 120 milliseconds, you are in a safe zone. The first thing, you're in a safe zone. Because this patient is having a tachycardia from above. Whenever you see a narrow complex tachycardia, no fear, go give intravenous adenosine. The point of adenosine is give as central as you can, either brachial or go, if you have an opportunity of a neckline, very good, otherwise go here. Give 6 milligram and push with 20 ml saline. Ineffective, you can give 12 milligrams. Ineffective, you can give 18 milligrams, but push with 20 ml saline. That's one. Supposing the patient has a wide complex tachycardia, that means the QRS is more than 120 milliseconds. You don't know anything about the patient. Just shut your eyes, tell yourself it is ventricular tachycardia, and I will treat it like ventricular tachycardia. So when you see a wide complex tachycardia on an EKG, and if you are in a hospital setting, wide complex tachycardia, do not give adenosine, but if the patient is hemodynamically stable, you may want to give intravenous amiodarone because it is a monomorphic VT. If the patient has compromised hemodynamics, the best, and you are in an emergency room of a hospital, call your anesthetist and say, I want to cardiovert the patient. Synchronized cardioversion, and the patient will be out of the arrhythmia. The problem comes in the emergency room if the patient has wide complex tachycardia, and now you try to understand, is this a VT or is this SVT with aberrancy? You should always leave this academic discussion after you have treated the patient. You are very safe giving the patient intravenous amiodarone. You are 150 bolus followed by 300 milligram IV 8 hourly. You are very safe in cardioverting the patient. There is somehow a hesitancy to cardioversion. Remember, cardioversion is one of the safest techniques to be done to terminate a tachycardia. So remember, narrow complex, adenosine, wide complex, amiodarone. Wide complex, if it is polymorphic, means it is changing with every beat, just defibrillate the patient.
My only question still remains, when you have got narrow ventricular tachycardia, narrow QRS ventricular tachycardia, where gives you confusion? Because normally we all think it is a supraventricular, but when will you say this is ventricular tachycardia?
So whenever you have a tachycardia which is relatively narrow, even that puts you in a safe zone. Why? A narrow ventricular tachycardia typically are idiopathic VTs. They are VTs which are arising either the fascicular VT, which can be a narrow complex tachycardia, and sometimes can be VTs which are arising from the septal area. Only then will a VT be narrow. Otherwise, the VT will always be wide. So remember, if you have a VT, because you can see AV dissociation, don't worry. You can give amiodarone to those patients. You can even give intravenous verapamil if you are sure the patient has no structural heart disease and it can convert.
Thank you. Thank you.
All narrow complex supraventricular tachycardia, whether NSVT or anyone, they will respond to the till they arrive to the ER or for the carotid massage. All of them.
Yeah. You're absolutely right, sir. I think we're running short on time. So, yes, you did carotid sinus massage. There is no problem. Narrow SVTs, patients will never die.
You should give a big hand for both the speakers for an excellent talk. Thank you. Thank you.
Thank you so much, ma'am. It was indeed a very informative session. I would now request the honorable chairpersons to felicitate the speakers, please. Dr. J.K. Sharma, sir. Dr. Aparna Jaswal, ma'am. For our next session, I would like to invite for our keynote address our Honorable Chairpersons, Professor M.V. Jolly sir and Professor Sudhir Sachdev sir. Sir, I would like you to introduce the speakers. Thank you.
Welcome to the 5th Annual Conference of Innovative Physicians Forum. I am privileged to introduce one of the most eminent personality, Professor Mark Strachan, the Secretary of Royal College of Physicians of Edinburgh. He is the consultant in diabetes and endocrinology, Western General Hospital of Edinburgh, the Secretary of the Royal College of Physicians of Edinburgh. He is also the editor of Davidson's The Principles and Practice of Medicine, which everyone knows about it. And his main research interests are on C-peptide, especially in diabetes, the effects of diabetes on the brain and liver, thyroid cancer, and neuroendocrine tumors. Today, he would be addressing keynote address, Safe Prescribing of Long-Term Steroids. I welcome Professor Mark for the presentation.
Thank you very much indeed. Good morning, everyone. It really is an absolute pleasure to be here in person in New Delhi today. I'm actually at the start of a 2-week visit to India, which I'm really very, very excited about. So what I'm going to talk about today in terms of steroid safety is really something that will actually be familiar to all of you in the room. There's really nothing that I'm going to say that is going to be a surprise. But when it comes to the prescription of steroids, it's something, certainly in the UK, that we don't generally do very, very well. And people often come to harm as a consequence of long-term steroid therapy. That's despite the unquestionable benefits of the treatment for the condition that it's being prescribed. And as we all know, steroids are almost ubiquitous in medicine. There can't be many specialities where high-dose steroids aren't prescribed. Before I got into the main substance of the talk, I just wanted to just say a little bit about relative potencies of the different glucocorticoid steroids and what we mean by physiological and supraphysiological steroids. So a common dose of prednisolone that's prescribed is 40 milligrams per day. We might see that in acute asthma or COPD. That's equivalent to 4 milligrams of dexamethasone. Now, I'm certainly very used to see my colleagues in oncology prescribing 16 milligrams of dexamethasone to somebody who's come in with spinal cord compression. And that really is an industrial dose of glucocorticoids. For a long time, it was believed that the physiological amount of steroid was an equivalent of 7.5 milligrams of prednisolone per day. That's in turn equivalent to 30 milligrams of hydrocortisone. So in conditions like Addison's disease and hypoadrenalism in general, it was quite common to prescribe a 20 and 10 milligram regime of hydrocortisone. But actually, we know now in careful studies that have been done looking at the amount of cortisol that's produced in the human body, that actually the physiological amount of prednisolone is about 3.75, approximately 4 milligrams of prednisolone per day. So if you're giving more than 4 milligrams of prednisolone, you are giving a supraphysiological, or what I would think of as a pharmacological dose of glucocorticoids. So when do side effects with steroids occur? Well, there is no absolute cutoff. There is quite a substantial degree of inter-individual variation in susceptibility to side effects. So all you can do is sort of make sort of vague, sweeping statements. And my first bullet point is a classic example of that sort of thing. So as a general rule of thumb, the higher the dose of steroid that you're given, and the longer that you're giving it for, the more likely that side effects will occur. That's a pretty obvious thing to say. As a general rule, it's very unlikely that you will see significant systemic toxicity from topical or inhaled steroids, but you can do. If you're giving very, very high doses of inhaled steroid, if you've got somebody with very bad erythroderma who you're giving huge amounts of topical steroid, you can get systemic absorption that will have an effect. And there are drugs, and I've put at the bottom, the classic is ritonavir in HIV, drugs that inhibit the natural metabolism of steroid, that if you're taking, effectively cause a very significant potentiation of the steroid dose. And I've certainly seen, particularly with inhaled steroids, co-prescription of ritonavir resulting in effectively very severe Cushing's. As I said, classically 7.5 of prednisolone was considered the physiological equivalent, although we know that actually is supraphysiological. But as a general rule, if you're on more than 7.5 milligrams of pred for more than 3 months, that's when you really, really have to start thinking about long-term toxicity. But because that 7.5 dose is supraphysiological, you do see side effects at lower doses, and there are some susceptible individuals that will get toxicities from 5-6 milligrams of prednisolone equivalent. Now, the first thing to consider is the impact of that exogenous steroid on the pituitary and the adrenal glands. So it doesn't matter what dose of glucocorticoid or steroid that you're giving to someone, it will cause suppression of ACTH and cortisol. Again, the degree of suppression depends on the amount that you're giving. So if you're giving 1 or 2 milligrams of prednisolone, you'll get a little bit of suppression of ACTH and cortisol, but not massive. But if you're giving more than 4 milligrams per day, more than the physiological equivalent, then effectively you will get complete suppression of ACTH and cortisol. And over a prolonged period of time, that suppression will result in atrophy of both the adrenal cortical cells and the cells in the pituitary that make ACTH, the corticotrophs. So you will actually get functional atrophy or structural atrophy of those cells. How quickly that atrophy can recover, again, is determined by the dose and, more importantly, the duration of the therapy. If you've been on a supraphysiological dose of prednisolone for, say, 5 years, you're going to struggle for those atrophic cells to fully recover, even if you taper down the dose of steroid. It's not impossible, but it's more of a struggle. The practical consequence of that atrophy of the adrenal and the pituitary cells is that if the individual stops taking the steroid therapy, they are then at risk of adrenal crisis, because they will suddenly go from being awash with exogenous steroid to having none at all. Now again, that's something within endocrine practice. When you're dealing with patients with Addison's disease, other forms of hypoadrenalism, we do spend a lot of time in counselling patients what to do during acute intercurrent illness. We normally advise them to take a higher dose of hydrocortisone to mimic the physiological rise in steroid levels that occurs during intercurrent illness. And we advise them often to take injectable hydrocortisone if they have a vomiting illness, if they're not able to take oral steroids. But I think this is something that we're not so good at doing, where people are being given therapeutic doses of steroid therapy. So in gastroenterology and rheumatology and neurology practice, I think we're less good at giving people advice on what to do with their steroid therapy if they get intercurrent illness or if they start vomiting and are not able to take the tablets. And I won't list this is on the slide here. I've got an excerpt from one of our patient leaflets for steroid therapy. So I'm not going to go through the symptoms of adrenal crisis. You'll all know that. You'll all have seen people in with adrenal crisis in your hospitals. But the general advice that we give people is that if they are on a dose of prednisolone, a daily dose that's 10 milligrams or more, they don't need to double that up during an intercurrent illness. They just need to ensure that they're getting it. And if they're not getting it, then they either need to get to hospital and or take a rescue dose of injectable steroid. But if their dose of prednisolone is less than 10 milligrams, then that dose should be increased up to a 10 milligram equivalent during intercurrent illness. This is a standard NHS leaflet, the classic steroid card that people are advised to carry to alert healthcare professionals that they're taking steroid therapy. We also encourage people to wear an alert bracelet or some other tag that lets people know that this is an individual on long-term steroid. So that's adrenal crisis. The other side of the coin, of course, is Cushing's syndrome. Now, again, we all know what the signs and symptoms of Cushing's syndrome are. This is something that is drummed home to us at medical school. So the commonest cause of Cushing's syndrome that I see as an endocrinologist is iatrogenic Cushing's syndrome caused by exogenous steroid therapy. That's overwhelmingly the commonest cause of Cushing's syndrome. And as I said earlier, this tends to be dose and duration dependent, but with incredible inter-individual variability. I've seen iatrogenic Cushing's with people taking 6 or 7 milligrams of prednisolone. On the other side of the coin, you see people taking 20 milligrams of prednisolone. They've been on that dose for a long time, and they don't have Cushingoid features. One of the key features of Cushing's syndrome, a silent feature, is osteoporosis. So steroid therapy has a very, very negative effect on bone mineral density. Now, we all know that osteoporosis in general has got a very complex etiology. There are many, many factors that contribute to our bone density. Of course, we know that bone density declines as we get older. It declines particularly in women as women go through the menopause. It's associated with low body mass index, particularly excessive exercise, And things like smoking and alcohol excess also diminish bone density. And then, of course, there are health issues such as hypogonadism, such as chronic inflammatory illness and malnutrition, which will also diminish bone density. So you have to factor all of that in when you're considering bone density in people on long-term steroid therapy. When it comes to steroid therapy, glucocorticoids have a particular negative effect on the trabecular bone of the spine. They have an effect on the cortical bone in the long bones, but spine is the particular area that is susceptible. And the other key thing that's really, really important to remember about glucocorticoid-induced osteoporosis is that in this form of osteoporosis, for a given bone density, the risk of fracture is much, much higher than in, for example, postmenopausal osteoporosis. So again, you can have a T-score of, say, minus 2.2 in somebody on steroids, which would be defined as osteopenia, not osteoporosis, but that person can end up with terrible, terrible vertebral fractures as a consequence. So steroid therapy has a big negative impact on the quality of bone as well as the amount of bone that's there. Now, there are very complex algorithms. This is an algorithm that comes from the US that recommends that we should be thinking about bone density in any adult taking more than 2.5 milligrams of prednisolone or equivalent for more than 3 months. I think that's quite interventional, and the levels of investigation and assessment that they recommend, again, are quite detailed, and I think for many of us would think, oh gosh, that's quite a lot to think about. So I have to say, personally, I'm generally thinking really about bone protection in people who are on a daily dose of prednisolone of more than 7.5 milligrams for more than 3 months. And if somebody's got particular other risk factors for osteoporosis, I would be thinking about it if they're on more than 5 milligrams of prednisolone. And of course, that bone protection would be bisphosphonate therapy. In the hospital that I work in, about once or twice a year, we get somebody admitted with a hyperglycemic crisis that has been precipitated by steroid therapy. So this would typically be a pre-diabetic person or an unknown diabetic who's been given high-dose steroid to treat a comorbid health issue. And several weeks later, they come into hospital with extraordinarily high glucose. I've seen people die. I've seen people lose limbs as a consequence of hyperglycemic crisis precipitated by steroids. The people that are most at risk of steroid-induced diabetes are actually people who are most at risk of type 2 diabetes. So it tends to be older, again, everything that we're familiar with. Older people, individuals who are overweight, people of ethnicities that we know that are associated with diabetes susceptibility, and broadly speaking, individuals who are pre-diabetic. Again, this is just our local guidance. Probably the most, if you're not known to be diabetic, the most predictive factor in whether or not you'll get steroid-induced diabetes is to check an HbA1c at the time you start the steroid therapy. If the individual has a diabetic range HbA1c, then that's only going to get worse with the steroid therapy. And if they're pre-diabetic, you're likely to precipitate diabetes with the steroid therapy. So we would get both groups of individuals doing finger prick blood glucose monitoring in that situation. If they're in a low-risk category because of HbA1c, we would just probably give them a warning about symptoms to look out for with periodic monitoring of HbA1c. In terms of treatment of steroid-induced diabetes, the classic treatments for it are still sulfonylurea therapy and insulin. And again, that's all tailored around home blood glucose monitoring. So again, as a general rule, people are getting sugar levels consistently more than 12 millimoles per litre on steroids. We would be advocating stepping up therapy. A third group to consider is cardiovascular disease. We know that people who get Cushing's get higher blood pressure, they get diabetes, as we've just discussed, they get central adiposity. Also has effects on things like blood viscosity. So there is now a very, very large literature that steroid exposure increases risks of cardiovascular disease, and that includes both atherosclerotic cardiovascular disease and heart failure. When it comes overall to considering the risks of glucocorticoid therapy, you obviously have to consider the health problem that you're giving the steroids for and other comorbidities, what their prognosis is. That's probably particularly true for osteoporosis and cardiovascular disease, where changes occur over a more prolonged period of time and where any interventions that you might put in place to mitigate those side effects take place over a more prolonged period of time. I've discussed diabetes, risk of adrenal crisis, osteoporosis, and cardiovascular disease. And you'll see I've put a sort of approximation of the risks of these things for two commonly prescribed doses of prednisolone. So diabetes is more of a risk the higher the dose of prednisolone that you give, whereas paradoxically, the risk of adrenal crisis is higher in people who are on lower doses, because if they don't double up their steroid therapy during intercurrent illness, they're more likely to get that adrenal crisis. Whereas if you're already on a high dose, your risk of adrenal crisis is not going to be material unless you suddenly stop taking it or you're not able to take it because you're vomiting. So, think diabetes, think adrenal crisis, think bone protection. I haven't mentioned gastroprotection. Most studies say that gastroprotection really only needs to be considered with high-dose steroid therapy in people who are at high risk of gastrointestinal bleeding. That's particularly people with known peptic ulcer disease or a previous GI bleed, or if they're anticoagulated or have active cancer. In terms of mitigating these risks, as I say, in terms of the adrenal crisis, it's all about sick day rule guidance. What do you do if there is an intercurrent illness, or if I run out of tablets, or if I can't take them? Cardiovascular mitigation is all about the standard things that we all know about: blood pressure, statins, and the like. For diabetes, it's about giving people information about it, about the side effects that they need to look out for, monitoring as appropriate. And that would either be HbA1c monitoring in people who are at low risk, or finger prick monitoring in people at higher risk. Bisphosphonates are a very effective means of reducing risk of fractures in any form of osteoporosis. We certainly use a fair bit of IV zoledronic acid on an annual basis in people who will struggle to take weekly oral therapy. Calcium, vitamin D, lifestyle factors are important, but have got actually less of an evidence base in this context. And then the final thing I just wanted to touch on is about weaning long-term steroids. So somebody who's, say, had polymyalgia rheumatica, who's been on prednisolone for a long time, and you're wanting to cut back on the dose. in our centre, we advocate that you wean down the dose down towards that physiological level, that 4 milligram mark. And you do that according to the symptoms of the person's disease for which you were giving them steroids in the first place. So, you'll be guided by their bowel symptoms if you've given it for inflammatory bowel disease, or their aches and pains and their ESR if they have polymyalgia. When you get down around about the 4 milligram mark, measuring a 9 AM cortisol is very, very helpful in predicting the degree of adrenal suppression. So if that cortisol level is good, in our local range it would be over 425. You'll have different ranges depending on the assays that you're using. If they've got a good cortisol on that 4 milligram dose, you can just stop the prednisolone straight off. You don't need to taper it down any further. But if the cortisol level is very low, below 275 in our centre, then you have to take that tapering down below 4 milligrams very, very slowly, and again give very, very clear worsening advice for the patient on what symptoms to look out for and what to do if they become unwell. Now you may say, well, come on, this is I've been weaning off steroid therapy for years. My patients don't come to any harm. I never see a problem like this. And you may well be right. But I'm just going to show one study, which was a Scandinavian study that looked at admissions to hospital with any one of these things, either symptoms or signs or physiological parameters. And these are all things that you might be associated with hypoadrenalism or an adrenal crisis. And they looked at these admissions to hospital with any of these parameters over a 12-month period prior to cessation of steroid therapy and 7 months after cessation of steroid therapy. And you can see that in the period around about the withdrawal of the steroid therapy, there was an absolute spike in admissions to hospital with this. It's a very, very real problem, and I think that's something that is under-recognised when people are tapering down. So, thank you very much indeed for your attention. I say this, I think is a genuine issue that is often not done very well, and is certainly not done well in my own centre. Adrenal insufficiency is a risk for all people on long-term steroids. Higher doses will precipitate diabetes, especially if the HbA1c is not normal prior to commencement. Bone health is an issue in people on higher doses in the long term. And don't just stop the steroids. Think very carefully about your tapering regime. Thank you very much indeed for your attention.
Thank you, Professor. Thank you, Professor Mark. Thank you, Professor Mark. It was wonderful that you enumerated the whole lot of safe prescribing of long-term steroids. We understood as in earlier days that we should be mastered in 3 sons, that is the Hutchison, Harrison's, and Davidson. Today we have the main person from the Davidson itself, editor.
Thank you. Thank
I congratulate you, and now the subject is open for discussion. Open for questions.
My question is, sir, is that do we need to do bone densities in patients regularly and at what intervals?
So if you follow the American guidelines, then yes, you would do an assessment of bone density. I'm not sure it's absolutely necessary. If I'm honest, being just pragmatic, you know, if you have, let's just say, a 60-year-old woman whom you're starting on steroid therapy, you know she's going to be on that treatment for a prolonged period. I would start a bisphosphonate, whatever her bone density is, and I don't think that needs to be. You know, you don't need to do a measurement beforehand, and you don't need to monitor it afterwards. The treatment is the same, whatever the DEXA scan is going to show.
Okay, just a small out-of-the-box question. Recent pandemic COVID, there was a lot of use of steroids amongst the individuals who were admitted. And I was wondering, was there any effect on the C-peptide, which was the main subject of interest, the high use of steroids and C-peptide levels? Was there any decline in C-peptide or something? I call it as a pancreopause. Some amount of there was an...
Well, there's no doubt, obviously, that during COVID, certainly in the UK, COVID seemed to have a very bad effect on the pancreas. So we saw a lot of people coming in with COVID with really terrible hyperglycemia in the context of acute COVID infection. Now, some of those were probably people with undiagnosed diabetes, and just the stress of severe intercurrent illness was causing significant hyperglycemia. There is evidence that COVID itself has a specific effect on pancreatic beta cell function. It's toxic to the beta cell. It damages the beta cells. There's been a suggestion, actually, that there's been an increased incidence of type 1 diabetes in the aftermath of the COVID epidemic. So I think there are direct effects. And then, of course, as you say, steroid therapy on the top of that is pouring petrol on the fire of the blood glucose levels. So it was certainly very, very challenging as a diabetes service managing the huge numbers of people in hospital with very poorly controlled glucose during the course of COVID. In terms of long-term consequences of that on pancreatic function, on susceptibility to diabetes and whether the diabetes went away, I think the data is still emerging on that, but I think there are definite signs that COVID has a negative effect on the beta cells.
Thank you very much.
Sir wants to ask something.
There is one problematic situation when patient is suffering from SLE or chronic ulcerative colitis, also had diabetes and hypertension. You need to give those therapies plus steroid. How are you going to control the side effects or aggravation of those conditions? Already hypertension, diabetes, and ulcerative colitis or SLE. Now they are requiring antihypertensive, they require anti-diabetic, and also steroid. So side effects or adverse effect of steroid, how can we minimize?
Yeah, so you're right. Those are conditions that are inherently in themselves associated with increased cardiovascular risk. They are, as you say, the people will often be on preventative therapy at the time, and I think all you can do is do your best and at least think about it. And, if they're on, I still see people, coming in with diabetes on relatively low doses of statins, despite the guidance that they should be on higher doses. So you may have the option of increasing from, 10 milligrams of simvastatin to 40 of rosuvastatin to really maximize cardiovascular risk protection. And if their blood pressure is down to target, then that's good. But obviously, if it's above target, then there will, you'll just want to absolutely step hard on blood pressure lowering therapy. But it's hard. I accept that.
Yes.
The question is, if patient is poor and diabetic and on high dose, say prednisolone 60 milligram per day for 3 months or more, then is it some protocol of monitoring the high dose of to the patient?
You mean in terms of monitoring their blood sugar levels? Do you mean, is there a protocol for monitoring the sugar levels in that context? So yeah, well, we would, in that situation, we would very, very much be ensuring that that person is either finger prick testing, and that should be a minimum of 4 times a day. In some parts of the world, they might give them a flash continuous glucose monitor to monitor the sugar levels. What we know is that in steroid-induced diabetes, glucose levels tend to rise across a 24-hour period. Glucose levels tend to rise in the late afternoon and early evening. That's when they're at their peak. So one of our protocols is that we particularly get people to check their sugar levels before their evening meal and after their evening, 2 hours after their evening meal, to see if there's a large postprandial spike. And if that is elevated, then they'll target that with appropriate therapy, either sulfonylurea or insulin, depending on the level of sugar and what therapies they're already on.
This is the last.
Yeah. Thanks very much for your talk, Professor Strachan. But you know, it's traditionally taught that oral steroids should be administered in the morning. But is there any evidence that it makes any difference to any of the problems that you've described?
Yeah, no, it doesn't. So that's recommended because physiologically cortisol levels start to rise and are their highest first thing in the morning. So it's trying to mimic physiology. But in terms of any of the issues we've discussed, no, that doesn't. It's the total dose of steroid that's important.
So it was a wonderful description. On behalf of IPF and on behalf of the revered physicians sitting here, we appreciate your presence and your lecture. Thank you very much. I think we should clap once again.
Thank you very much. Thank you. Thank you.
Thank you so much, sir. I would like to request our honorable chairpersons to kindly felicitate the speaker, Professor Mark Stratton, please. A quick announcement, please. I would request all the PG residents to proceed for the poster presentation. All the PG residents to please proceed for the poster presentation. Yes, sir, for next you will have the next section. For a presidential oration, I would like to invite our chairpersons, Dr. Sunil Wadhwa, sir. Sir.
Give him a big hand. Thank you so much, Sudhir, for sparing time for us. Thank you. We would also request you to kindly honor Dr. M.V. Jali, Director, KLE Institute, a name in diabetology. Give him a big hand. Thank you so much, Dr. Jali. Thank you. Please proceed further.
For our next session, for the presidential oration, I would like to invite our honorable chairpersons, Dr. Sunil Wadhwa, sir, and Dr. Dinesh Sharma, sir.
Good afternoon, ladies and gentlemen. From good morning, we have entered into the good afternoon phase. And now we have presidential oration. Dr. Meena Chabra will be delivering the oration on evolving landscape of type 2 diabetes management. Dr. Meena Chabra doesn't need any introduction, but I am introducing her because I want professional satisfaction. Otherwise, as a chairperson, I will have nothing to do. Well, as it is customary that no questions are permitted in presidential oration, so please mind it. Dr. Meena Chabra is consultant in Sir Gangaram Hospital.
Dr. Meena Chabra is senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi. She is chairman RSS DI Delhi chapter and chairman Innovative Physicians Forum. She is the part of committee on joint consensus on guidelines on management of diabetes by RSS DI and ESI 2019. Distinguished Service Award 2018 by Delhi Medical Association. Received Dr. B.D. Kumar Oration Award 2019 for excellence in field of cardiology and Indian Medical Association 2019. RSSDI Award for excellence in diabetes care 2019. Diabetes India Center declared among top 40 centers of India for creating awareness about diabetes through various initiatives during the year 2016. Now over to Dr. Meena Chabra, please.
Thank you, chairpersons. And it's my proud privilege to present my oration. And my topic today is evolving landscape in type 2 diabetes. And why did I choose this as my topic? Because this century has seen a lot of evolution in management of type 2 diabetes. I'll be talking about evolution in the prevalence of type 2 diabetes. It's increasing all over the world, but in our part of the world, it's increasing in leaps and bounds. Changes in pathophysiology, changes in anti-diabetic therapy. We have several new drugs in our armamentarium. Changes in how we look at cardiovascular risk reduction, kidney protection, and CKD progression. Also, the guidelines have changed. Technology has come to our rescue, and the economics of diabetes is ever changing. Now, diabetes is a huge and growing problem. And if you look at this slide, you'll be actually surprised that we already have 387 million people who are diabetic in the world. And this number will increase by 205 million by 2035. So friends, I would like to reiterate that whether you are a general physician, a consultant, an endocrinologist, a neurologist, or a cardiologist, you will have to see a diabetic patient in your lifetime. So that is why the importance of this oration in this physicians forum, that we learn how the guidelines have evolved, how technology has evolved, and how we have to keep in pace with the evolution. So that's the gist of my oration. Friends, and my humble request, keep in pace, keep running, keep in pace with the evolution that is happening. Look at India, 74.2 million diabetics in India, and in 2035, we are going to be 124 million people with diabetics. We don't have enough doctors to handle this huge epidemic. Now, a little bit about different phenotypes. So all type 2 diabetics are not similar. You are surprised, some of them are type 2, they are obese, they are severely insulin deficient and insulin resistant. So we have these phenotypes. They're called SID, severe insulin deficient diabetes. We have IROD, which is insulin resistant and obese diabetes. We also have combined insulin resistant and deficient diabetics. And then we have mild age-related diabetes. We also have MOD, or mild diabetes, which is related to obesity, but I'm not discussing this. So you have to remember that treatment might differ according to the phenotype. Now, again, very interesting slide. The most common etiology of diabetes in the young, with young I mean up to age 35, was definitely type 1. But look at the change that has been happening. And a prospective study of 105 Indian youth, we found that type 2 diabetes now accounts for only 40%, type 1 40%, fibrocalculous pancreatic diabetes 15%, flatbush diabetes, these are the ketosis-prone type 2 diabetics, 2%, MODY 2%, and mitochondrial diabetes 1%. So again, the scene is changing. Even in the young diabetics, it may not necessarily be type 1. It could be other forms of diabetes. I am a part of this registry. It's called the YDR, the Young Diabetes Registry, where we are registering all diabetics aged less than 25. And we've been noticing an increase in the incidence of type 2 diabetes in the young because of lifestyle changes, because of westernization of our diets, and also because of less activity. Now, changes in the pathophysiology. So we were traditionally taught that there is insulin resistance. To overcome the insulin resistance, the pancreas secretes more insulin. Ultimately, pancreatic insulin secretion can no longer overcome the resistance, and we have type 2 diabetes. But after the historical lecture of De Fronzo in 2008, where he spoke that we have to move from the triumvirate to the ominous octate of type 2 diabetes. We have 8 pathophysiologies of type 2 diabetes. So we do address the incretin effect. We also talk about the kidneys. So we will be talking about drugs that help there, the sodium glucose co-transporters, the receptors there. Then we have the increased lipolysis. So there are several other pathophysiologies. And again, this is an evolution from triumvirate to the ominous octate. So what is the clinical implication? Now that we know that there are multiple pathophysiological defects, we need to target as many pathophysiologies as we can with individual drugs. So we have to hit harder and we have to hit fast, because we know that the beta cells are dying, or there is apoptosis or programmed cell death. So we have to hit harder, we have to hit multiple pathophysiologies by various drugs. So these multifactorial considerations are very important when you choose an anti-diabetic therapy. So now the focus has shifted from a glucocentric approach to a vasculocentric approach. So it's not anymore about decreasing the HbA1c, it's also about decreasing the micro and macrovascular complications by addressing various pathophysiologies. Now here I like to tell you that in spite of therapeutic advances, just look at the number of drugs we have in our armamentarium, neither the mortality nor the morbidity has gone down. What is the reason? Again, a huge glucocentric approach among all of us. We have to remember to use drugs which decrease the fasting postprandial and HbA1c without causing hypoglycemia and without causing weight gain, and giving some more pleiotropic benefits, which we will see some of the drugs have. But there is underutilization of these drugs. So we need more and more CMEs to actually promote the thought, generate this thought that yes, there are therapeutic advances, there are more and more drugs which have pleiotropic benefits, and we should be using them. So the first step, doctors, in your clinics, when a type 2 diabetic patient walks, is not a glucocentric approach. Your aim is not just to decrease the blood sugar. And I feel that my oration will be successful if I can convey that the first step is to calculate the eGFR and to calculate the atherosclerotic cardiovascular disease risk. It's very important. You can use any risk engine on your phones. Your antenna will be up if you know, oh, my patient is not just diabetic, he's dyslipidemic, he's hypertensive, he has history of smoking, he has a family history of a first-degree relative dying prematurely of cardiac arrest. All these things should prompt you to list him as high ASCVD risk, and that's when you will decide to treat him with a different drug in your armamentarium. So let's just move ahead in how we manage diabetes, and let's just get rid of therapeutic inertia. that we all have, and also that we do not de-learn what we have been taught, that sulfonylureas are the best drugs because they're very efficacious and they bring down the HbA1c. So your aim should be bringing down blood sugar gently without causing hypoglycemia and without causing weight gain, at least weight neutrality. We must address obesity, we must address lifestyle. Now, what is wrong is that we have so many drugs. In spite of that, just see, almost 75% of our patients have not reached the magical figure of an HbA1c of less than 7. What is our expectation from newer anti-diabetic drugs? I just told you. These are the expectations. Yeah. So I'll stop by to welcome our chief guest. A very warm welcome, sir. Yeah. And it's our privilege to have you among us. Thank you so much. So, sir, we are talking, my oration is actually about addressing how the management of type 2 diabetes is evolving and what, as clinicians, whether we are from any specialty, what we should be thinking about out of the box. So thank you for joining us. Now, expectation from newer anti-diabetic drugs is, I just told you, low risk of hypoglycemia, minimal off-target effects, proven cardiovascular benefits, a good glycemic control, and if not weight loss, at least no weight gain. Now, what are we trying to achieve is very simple. We don't want only glycemic control. We want to decrease microvascular and macrovascular complications. In the UKPDS, when the blood sugar was controlled better in that arm, there was reduction in microvascular complications, but it did not translate into statistically reducing macrovascular complications. Again, proving that it's not a glucocentric approach, but a vascular-centric approach where we need to control the blood pressure and the cholesterol also, and other risk factors. So therefore, there is a call for a paradigm shift in the management of diabetes, and I think this is the crux of my talk, that we move from a glucocentric approach to an approach where we not just lower the HbA1c, but we protect the vasculature. So this is very important. Treatment should be based upon reversal of known pathogenic abnormalities and not on simply reducing the A1C. So I was present when Ralph D. Fronzo gave this Banting lecture in 2009. Now, there have been dramatic changes in the guidelines, and they have been in line with the new drugs that have been coming. So the Accord, the VADT, and the DCCT, these were trials to compare glycemic efficacy. Now in 2008, after the rosiglitazone fiasco, that rosiglitazone increases cardiovascular risk, the US FDA mandated cardiovascular outcome trials for each and every anti-diabetic drug. And this was a benefit for us because a decade of cardiovascular outcome trials, we had a handful of trials with cardiovascular benefits, but wow, we had trials which told us which drugs to use, and now we have trials on GLP-1 receptor agonist, so much so that we have the oral GLP-1 now available in India. We have trials on SGLT2 inhibitors. So guidelines have changed. See the guidelines in 2016. So guidelines in 2015 said glycemic control was important. In 2016, we started talking about cardiovascular and other benefits on mortality. In 2018, we started talking about chronic heart failure and ASCVD. In 2019, we have endorsed that GLP-1 receptor agonist and SGLT2 inhibitors have proven cardiovascular benefits, and so much so that the European Society for Cardiology said that if a patient has heart failure and type 2 diabetes, you can give SGLT2 inhibitors even before you start with metformin. And in 2020, again we say, the ADA says so, that independent of HbA1c, if the patient has established atherosclerotic cardiovascular disease, has heart failure, or has chronic kidney disease, you could start with either a GLP-1 receptor agonist or an SGLT2 inhibitor. So these are the evolution of guidelines. You could see these. It's a busy slide, but again I reiterate that all you have to do when you get back to your clinics is calculate ASCVD risk, always calculate the eGFR, check for albumin creatinine ratio, don't miss doing simple tests in the patient, and just continue to manage the blood sugar. which we've been seeing very often. So now, ADA, this is the cardiovascular disease and risk management. The 4 pillars of management according to ADA is again what I've been talking about, management of glucose and to prevent complications. Of course, ADA says A, B, C, A1C, blood pressure and cholesterol. So doctors, go back home and make sure that your diabetic patient is protected, his vasculature is protected. So these are important, and we must be using more and more agents with benefits on the kidney. And here we stand apart from the rest of the world because we have generics which are very cheap. So we have SGLT2 inhibitors, and they are now generics, and they are all affordable for most of our patients. Now, from glucose-centric to a beta cell-centric approach for management of type 2 diabetes. So the functional beta cell mass is reduced in patients of type 2 diabetes, irrespective of the presence or absence of obesity, resulting in increased workload of residual beta cells. So we know that there is a reduction in the beta cell mass and the beta cell function. So what we have to do is that we preserve the beta cells. So we should be using therapies which have some promise in preserving the beta cell mass. So SGLT2 inhibitors may have a beta cell mass protective effect. The GLP-1 receptor agonist may have this effect too. So there is a paradigm shift. We have moved from a cardiotoxic, say we know rosiglitazone or perhaps saxagliptin in one of the trials showed increased heart failure hospitalization, the savotimi. We moved to drugs like DPP-4, which can be prescribed on the phone during COVID. These were the drugs we wrote very often on our audio consultations. Then we moved to cardioprotection with SGLT2 and GLP-1. And now we have both cardio and renal protection with SGLT2 and inhibitors. So this is how the paradigm of the management is changing, and we have to keep in pace with the change. This combining treatments with complementary modes of action is again very important. So if you're using a drug like a glitazone, which will help the patient gain weight, you could combine it with an SGLT2 inhibitor, which will mitigate the weight gain that happens with glitazones. So you could use drugs which decrease insulin resistance, and along with the drugs which decrease, which have an incretin effect. So we can use drugs with complementary modes of action. Again, in India, we have combination pills available. These combination pills make compliance better, and they address multiple pathophysiologies and bring down the pill burden. So multiple failed attempts for oral insulin and GLP-1, this was the holy grail, but eventually we got the insulin, recombinant human insulins, the analogs, and finally the GLP-1 analogs in 2000. They're still very expensive, and most of our patients pay out of pocket. So they are difficult for our patients, but they are wonderful if we use them because they address the appetite, they decrease weight, and they prolong gastric emptyings, thereby the patient feels satiated. Now, so these are the cardiovascular and renal benefits, the various trials. We have evolution of basal insulins. So we had NPH insulin, which had to be used twice because the duration of action was not 24 hours. From NPH, we moved to U100 glargine, and from U100 glargine, now we have second generation basal insulins, degludec, and U300 glargine, which have lesser inter-individual variability, which have a prolonged 24, even longer than 24-hour action, so that you need not give it at the same time day after day, and improves compliance. We have evolution of bolus insulins. We have insulins now, something like fast-acting aspart, which is quickly effective, so that the meal can be taken even after, the injection can be taken even after the meal. These have revolutionized the management of diabetes. We have premixed insulin evolution. First, we had the usual biphasic human insulin, where 30% regular was combined with 70% NPH. Then we had the analog mixtures, and now we have the co-formulation, where the ultra-long-acting insulin degludec is combined with an ultra-short-acting insulin novorapid. So these are changes with needles. Look at this from the size of the needle and the pain. So from If you compare from 1985, there was a 27 gauge, 12 millimeter long needle. We have come to 2014 where there's a 32 gauge, 4 millimeter pen needle. So the pain has got down so that more and more patients can benefit from insulin devices and pens. Look at the change we saw with delivery devices, the evolution. We had needles and syringes, and then we moved on to pens, and we moved on to automated insulin delivery systems. So we have moved on. This is an evolutionary continuum. We had an open loop, then we have had a hybrid closed loop, and now we have a full closed loop where you can use the sensor which senses the sugar and it can send messages to your pump. So these are the pumps. Look at the first pump and now how the pumps have evolved. Continuous subcutaneous insulin infusion. Of course, in our part of the world, we don't have very many patients on the pump. I have about 25 patients of type 1 diabetes on the insulin pump, and we are now using sensors very regularly. What is distant management? Since we have a lot of youngsters here, what I would like to tell you that remote management of diabetes is possible. In the United Kingdom in NHS, I know that doctors would make phone calls to remind patients to get their fundus done, or to remind patients to get their albumin creatinine ratios done. We could protect a lot of kidneys, doctors, if we were proactive and did the albumin creatinine ratio. A dipstick test which is available in your clinics. We should be more proactive in looking at the fundus. If you can do it yourself, you can buy a fundus camera, you can even rent a fundus camera, or you can refer the patient to an ophthalmologist. So as a diabetes doctor, it's your duty to pick up microvascular complications. Now, telemedicine, now that it has been legalized after COVID, is one step ahead. So there are barriers. I know the biggest barrier is tech aversion. So it takes you some time to realize that technology is by your side. Technology is not that difficult. You can communicate better with your patients if you use technologies. So even your patient may be averse to technology. He may refuse to use a flash glucose monitor, but once you can show him another patient who's using, you can make peer group, you can make support groups, which I do, and then, it goes down, that the aversion to technology goes down. So data is the new currency. Again, my message via my oration is let's generate data. We are all guilty of not generating data in India. So this is a surprise to our audience from, not our audience, our mentors, our teachers who have come, professors who have come all the way from UK, that we don't have a good EMR, electronic medical records. They're lacking in most of our private clinics. So because we don't have electronic medical records, data is very sparse from our part of the world. Now, more and more of our youngsters, again, a call for all of you to go to EMRs, to record all your patients' findings, so that we generate more data and we can actually be wiser once we know what is happening to our patients. So evidence of benefit of technology, very, very simple. They were randomized to 3 groups. Usual quarterly follow-up. We tell our patients to come once in 4 months. Home use of a smartphone, recommending insulin doses with quarterly visits. And the third group, use of the smartphone with short teleconsultations every 2 weeks, but no visit. And doctors, I can actually tell you that patients whose insulin doses were modified by me on phone or in this study by the doctor had better HbA1cs than those who just came back after 4 months. So use this technology in your benefit of your patient, for the benefit of your patient. More and more patients can be controlled if you connect to them via technology. You could have apps telling them what insulin doses to take. You could have apps where they can fill in their sugars, and you could increase the doses of insulins or drugs if you use technology sensibly. Of course, we have continuous glucose monitoring. This shows the trend arrows and implications. More and more patients are now on flash glucose monitors and continuous glucose monitoring systems. Now, CGM targets, we must know time in range. We are moving ahead of HbA1c to time in range. What is time in range? How much in 24 hours, how much time was the patient in range? Because you don't want the patient to panic if one sugar is 250. It is the range which is important. And you should know degree of hyperglycemia and hypoglycemia. So degree 1 or stage 1 hyperglycemia when the sugar is 180 to 250. Grade 2 is when it is more than 250. And grade 1 hypo similarly is less than 70. And grade 2 is less than 54. Only 1% of the 24 hours the patient should be in grade 2 hypoglycemia. So 1% of 24 hours means only 15 minutes. So time in range is important. And now we are moving from HbA1c to time in range. And we've seen that time in range is correlated with peripheral neuropathy, with development of chronic kidney disease, with development of retinopathy also. So if time in range improves, microvascular complications decrease. So one line about medical nutrition therapy. We fail to focus on MNT. It's important. It's important to know fats, carbs, proteins. It's important to know saturated fat, unsaturated, polyunsaturated, monounsaturated. We must learn as physicians to talk about diet, which has been a neglected field. We need nutritionists to help us. We need more and more diabetic educators. Again, that's my message to the audience during my oration. We need to use MNT, medical nutrition therapy, where we need to give the right amount of carbs, proteins, the good fats. So this is important. And we know that diabetes remission is possible. Roy Taylor, his beautiful, elegant study where he said that people with ABCD, age is important, younger the age, BMI, higher the BMI, C-peptide, more the C-peptide, and shorter the duration of diabetes, you have a chance of remitting the diabetes. We don't use the word reversal because reversal conveys a message to the patient that he will no longer remain diabetic. The message should be that his blood sugar can be controlled or his HbA1c can be less than 6 for a while, and if it's possible, talk about remission. It's our duty to talk about remission, and remission was possible in the direct trial by giving 800 to 1,000 calories. So bariatric surgery, we all know, has been powerful tool in diabetes remission. AI technologies in our clinics, yes, not artificial intelligence has now come in a big way. Automated retinal screening could be done. Clinical decision support by AI. Predictive population risk stratification, and of course, patient self-management tools by AI. So to summarize, doctors, I would like to say that the landscape of diabetes is changing. And one line about economics, in India, 80% of our patients pay from their pockets. But we are actually lucky that we have generics which are available, so we can use the generics. We should be sure they are good quality and they have bioequivalent studies, and then we can use them safely. So increasing number of glucose-lowering therapies have proven cardiovascular benefits independent of glucose lowering. So please just don't use drugs for glucose lowering and a glucocentric approach. Use more and more drugs which have pleiotropic benefits, which do not cause hypoglycemia, because a single hypoglycemic episode lands the patient in the hospital, and there's a lot of cost to hypoglycemia management, and in an elderly, it could actually be fatal. There can be falls. Better insulins, early insulinization, please don't hesitate in starting insulin. Insulin injections are practically painless with the devices that are available. Use insulins that mimic physiological insulin secretion. Don't use irrelevant combinations, or don't use non-physiological, like using premixes with long-acting insulin. Don't do that, because the premix already has a long-acting component. Then please use technology. It's at your doorstep. Continuous glucose monitoring. The flash glucose monitors are available. The Libre sensors are freely available. You have apps which you can download. You don't need to buy the reader, which costs rupees 10,000. You can download apps like the Glimp app, and your Android phone, when you bring it near the sensor, it can read your sugar readings. It can sense the readings. Use more and more technology. HbA1c, remember, is a gold standard, but now we do have time in range, because it also talks about glucose variability. A clinic, if you are running a smart clinic, you can't do it alone, you can't do it all. So please rely on a good nutritionist, a diabetes educator, you need the help of a podiatrist, you may need a psychologist, and the other thing that I want to reiterate is please start keeping electronic medical records, they are important. Also start point of care testing. You could do a point-of-care urine albumin creatinine ratio with a dipstick. You could do a point-of-care HbA1c with a machine. You could actually use a handheld Doppler, and you could screen for peripheral vascular disease. Talk about remission or reversal of diabetes. We have patients, if you speak to them about remission, are very excited, and that's when they are motivated to lose weight. So talk to them about meal replacements, talk to them about healthy eating, talk to them about increased carbs and in our diets, and tell them to talk to them, particularly our vegetarian patients, talk to them about the importance of protein in the diet. So we are lucky that in India we have availability of cheap combinations. I'm not recommending combinations for every patient, but if possible, it brings down the pill burden, brings down the cost of therapy, addresses multiple pathophysiologies. So we could use combinations sensibly in a few of our patients. And of course, we also have the generics of SGLT2 inhibitors, so don't deprive your patients of pleiotropic benefits of these drugs if indicated. And we must recognize different phenotypes. So we are not all, every patient is different. This is called precision medicine. So you may have a lean type 2 diabetic patient who may be more insulopenic than insulin resistant and may need sulfonylurea to increase insulin secretion or may need insulin injections. On the contrary, you may have a type 2 diabetic who's morbidly obese, has severe insulin resistance, also reduction in insulin secretion, and he may be happier with medical nutrition therapy, metformin, and a GLP-1 receptor agonist, whether injectable or oral. So I would like to conclude, doctors, through my oration that whichever doctor you are, whichever specialty you are, a diabetic is going to touch your life sometime or the other. So it's better that we learn to evolve along with the evolving guidelines and the evolution. And the 20 years of this century have seen a lot of development in management of type 2 diabetes. So the message is go back home and turn your clinics into smart clinics. Thank you.
Thank you, Dr. Meena, for your masterly oration, as always. As I had mentioned earlier, that questions are not permitted in presidential oration. So let us come directly to the felicitation. Now, felicitating president is just like ulte baans bareli ko, inka gift inhi ko pakdana hai. So let us do the ceremony. Thank you.
I would request the Honorable Chairpersons to kindly felicitate our esteemed speaker, Dr. Meena Chhabra ma'am. I would like to call upon Dr. Anil Manchanda sir to felicitate our chairpersons, Dr. Sunil Wadhwa sir, and Dr. Dinesh Sharma sir. Dr. Dinesh Sharma sir. We will now like to proceed for inauguration ceremony, and I would like to call upon Dr. Dheeraj Kapoor sir for the inauguration ceremony.
Thank you so much, Dr. Ambika. It's indeed a pleasant responsibility to conduct the ceremony. So we are in the 5th year of the annual conference bit, and the audience on Saturday, which is a weekday for doctor, is so encouraging. So without much ado, I would invite the dignitaries to come for the lamp lighting ceremony, as we are aware that if science is the heart of any meeting, inauguration and paying obeisance to the Almighty is its soul. So without much ado, I would wish to invite for the lamplighting Dr. Meena Chhabra, our chairman, Dr. Puneet Khanna, our scientific chair, Dr. J.K. Sharma, our dynamic secretary, Dr. O.P. Sharma, a fatherly figure for all our conferences, our patron, Professor Hem Chandra sir, who has come all the way from Dehradun, Professor Andrew Elder, who's come all the way from Edinburgh, Dr. M.L. Swarnkar sir from Jaipur, Dr. Sudhir Sadeva sir, who's the Vice Chancellor, and Honorable Justice Mr. Ramanna sir, who's our guest today and blessing us with his presence, Dr. M.B. Jali, I would now request our President, Dr. Meena Chhabra, to please welcome Justice Ramanna sir. Dr. O.P. Sharma sir, to welcome Dr. M.L. Swarnkar sir.
As a matter of fact, when we said former Chief Justice, we should have also said that he is the father of a dedicated doctor also.
Dr. J.K. Sharma, sir, to welcome Professor Andrew Elder. Dr. Anil Manchanda, to welcome Dr. H.C. Pandey, sir. Dr. Sudhir Sadha, sir, to welcome Professor Mark Stracknan, President, RCP. Dr. Sachdeva, sir, again, to welcome Professor Kathleen White. With this, we come to the end of the felicitation bit. And now we have the welcome address by our President, Dr. Meena Chhabra.
So, good morning, and it's heartening to see a big audience, and it's my proud privilege and honor as the former president of the Innovative Physicians Forum, which is actually an academically oriented body, and we've been doing academic programs for the past 5 years. So it's my proud privilege to welcome all of you, all the dignitaries on the stage, and all our special guests who have traveled all the way from UK. A very warm welcome, and I hope all of you enjoy the academic feast for the next 2 days. Thank you. Thank you.
Dr. Puneet Khanna, the man behind science in this conference.
Thank you, Dr. Dheeraj. No, it's not men, it's the team of men and women behind this entire thing. So, respected dignitaries on the dais, eminent faculty, senior faculty in the audience, and my dear friends, on behalf of the scientific committee, I welcome you and express my thanks for your participation in the 5th annual conference, the Ipf Medicon 2022. The theme of this year's conference is Holistic Approach to Practice of Medicine, Need of the Hour. With this theme in mind, the scientific program has been meticulously designed by the scientific committee that includes Professor Arvind Gupta, Professor Vinod Ravindran, Dr. Anil Manchanda, Dr. Kathleen White, and Dr. Kerry Baker, the Director of Education, Royal College of Physicians. My thanks are also due to Dr. Kunur, he is not here, VP RCP Edinburgh, for his valuable inputs and support. This scientific program comprehensively covers important aspects of patient-centric, personalized care in many patients, routinely attended by all of us by internal medicine and allied specialties. The highlight of this conference are keynote addresses and orations by eminent physicians from India and the learned faculty from Royal College of Physicians, Edinburgh. Over these 2 days, we are going to hear about more than 30 state-of-the-art lectures, 6 very interesting hands-on workshops, a panel discussion tomorrow on the art of medicine that is going to deliberate on hot topics like communication errors, gender bias, and violence against physicians. We are also glad to have received more than 80 papers by enthusiastic postgraduates from all over the country. I'm really, really pleased to see your work. It's been a challenge to actually scrutinize your work and select the best 12 out of those papers for the oral presentation. And the posters are displayed for the 2 days outside, and really, really a big thank to all of you. It's also a matter of honor for all of us that IPF Medicon 2022 has been accredited 12 hours, 45 minutes of CME credit time by Delhi Medical Council. Friends, I extend my thanks to all these speakers and faculty for sparing their valuable time and honoring us with, by sharing their expertise. I'm sure this conference is going to be a very fantastic academic feast for all of you. Thank you very much for attending.
Thank you, Puneet, for setting the outline and the trend. Now, Professor J.K. Sharma, sir, the man himself.
Thank you, Dr. Dheeraj. It is my privilege to present before you all the Secretary's report. So, respected Chief Guest, Justice N.V. Ramna sir, Professor M.L. Swankar, Professor Andrew Elder, Professor Hemchandra, Professor O.P. Sharma sir, our patron and guide, Dr. Meena Chhabra, our President, Dr. Puneet Khanna, Dr. Dheeraj, Dr. Anil Manchanda, my friend, and everybody sitting in front of me, and my special thanks and recognition to my elder brother, Dr. C.B. Sharma sir. He is the person behind the guide, always keeps guiding me and my Bhaviji and my wife, Karuna. So if I'll start naming everyone, I know all members of IPF personally, one by one, so it will not be possible. We 11 physicians sitting together once decided that we should do the academic activities, and then we came forward in the year 2017. On 28th of March 2017, this body, Innovative Physician Forum, was registered as a regional body in Delhi with 11 the members. And then gradually, today we are 338 members. And I am very happy to see Professor K.C. Goswami sir. He is the professor and head of cardiology department at All India Institute of Medical Sciences. And he telephoned me that, JK, I would like to come and attend the ceremony. And I was so overwhelmed with that. Thank you very much, sir. We started with a motto of academic and education. So only academics and education we started with. And then we started having a bi-monthly CME and an annual conference and also a midterm conference. In 2017, it was started. In 2019, every year we are doing an annual conference, 2017, 2018, 2019, but in between also, in 2019, July, we had a midterm conference at SMS Medical College, my alma mater, and it was attended by more than 250 delegates. And then in 2021, 21st August 2021, we had the midterm conference at Mahatma Gandhi Medical Institute of Science and Technology at Jaipur. And we are very grateful to Professor M.L. Swankar sir for extending that 2023 conference will be in Jaipur at the Mahatma Gandhi Hospital. Thank you very much, sir. Looking at the academic performance of the Innovative Physician Forum, our IPF was recognized by Hemvati Nandan Bahugana Medical Education University, and Professor Hemchandra, the Vice Chancellor, he is here. Thank you very much, sir, for acknowledging our academic excellence and being an institutional member of Innovative Physician Forum. And Mahatma Gandhi Medical Education University is also one institutional member. Thank you, Dr. Sudhir Sachdev, for taking it forward. He is the Vice Chancellor, a good friend of mine. Then the KL University, Dr. Prabhakar Kore KL University, which is a deemed university. Dr. M.V. Jali sir is here. He is the CEO. Thank you very much, sir, for the academic partnership. But we did not stop here. When I approached Professor Andrew Elder, President Royal College Physician Edinburgh, and talked to him, he was very enthusiastic to have a association with Innovative Physician for all the academic activities. And this conference today is in association with this college, Royal College Edinburgh. And the good thing is that two people from the college, Dr. Kerry Becker, who is the education director, and Professor Conor Maguire, who is the Vice President International, they are the member of the scientific committee. So all scientific program has been designed in consultation and in approval with the Royal College Physician Edinburgh. And looking at that, the college also planned to have a convocation ceremony here in this particular hall today in the evening from 6 to 8 p.m. for their new fellows. So that program is for the college in association with Innovative Physician Force. So thank you very much. So we are open to all suggestions for academics, for education, for science. So with that, I will not take much time. I thank you everyone. Dr. O.P. Sharma sir has always been behind me any time. And my team, my friends, Dr. Puneet, Dr. Dheeraj, Dr. Anil Manchanda, Dr. Meena Chabda, of course. And we have amongst us Dr. Vinod Ravindran, who is the Joint Organizing Secretary. He is the rheumatologist at Calicut, and he is the International Regional Advisor of Royal College Physicians in Edinburgh. And he is here. Thank you very much. I can also see Dr. Manoj Desai, another regional advisor from Goa and Maharashtra. And everybody who have come from abroad and from India, many people from Mahatma Gandhi Medical College, my friend Dr. Puneet, my brother-in-law Dr. Dinesh Sharma, my Banja Sunil, and everyone. So thank you everyone. And I now hand over the proceeding to Dr. Dheeraj. Thank you.
Thank you so much, sir. Now, Dr. O.P. Sharma, sir, to please deliver the IPF Patrons Address.
A very, very good afternoon to all of you. 5 years ago, as Dr. J.K. Sharma mentioned, when we 11 physicians met, there are a couple of things which we decided at that time. We are still sticking to them. A, whatever the scientific program we do, it has to be need-based, not pharma-based. Yes, we took the support from everybody, but we were never guided on these issues. Second thing that we decided at that time, which our Secretary General, the live wire of the association has mentioned, that we always wanted to promote our youngsters, give them prizes, give them awards, recognize them for their papers. That's what we have been doing. So as a matter of fact, this was a forum little different. On this forum's 5th annual conference, let me take the pleasure of welcoming some of the dignitaries on the dais. Well, our guiding force, chairperson, our guiding force president of the forum, Dr. Meena Chabda, most respected former Chief Justice, Ramanna Saab. I had the privilege of meeting him a couple of months ago when he came to release a book on elastography by one of my classmates, Colonel Pant, who has been doing innovative work on breast cancer awareness. And he is also the father of a doctor. Our first academic partner, we can never forget it, Himati Nandan Baguna University. Welcome. Our another partner, Mahatma Gandhi University, Sonankar Saab, who is basically a name in Rajasthan for IPF and for his philanthropy. Our dear colleagues from abroad, Royal College of Physicians. And one thing, JK, you may add in your report, which you did very proudly, even during the COVID period, in an online meeting in which Royal College of Physicians of Edinburgh participated. Our Chairman Scientific Committee, some of the dignitaries I would like to mention who are off the dais. Catherine, welcome. Welcome Sachdevaji, the dynamic dean of Mahatma Gandhi University. Welcome Professor K.C. Goswami, Dr. Jali, General Kalra, friends, ladies and gentlemen. Well, the day we thought we will do something, कुछ मिलके चल पड़े राह पर log milte gaye, karma banta gaya. And today, the karma has been joined by many academic institutions also. At this juncture, as a patron of the organization, I would like to felicitate some of my members who have been burning midnight candles to make this program a great success. Dr. Meena Chhabra. Our innovator, live wire, the man who can mobilize people for coming to the conferences, the man who can mobilize institutions to join us, the man who can mobilize everybody to form an ideal scientific program, none other than Dr. J.K. Sharma. Give him a big hand. We are proud of him. The man who keeps the purse very tight, doesn't allow even a penny to be spent without a reason, is none other than Dr. Anil Manchanda, our great treasurer. The man who loves everybody, and if you call him, his ringtone is "Love You Zindagi." And the person is none other than Dr. Puneet Khanna, our chairman scientific. The person who has lot of patience, you talk to him, he will listen to you, then only give his argument. The one who has patience means Dheeraj, Dr. Dheeraj Kapoor. जो सबको मोहित कर देता है. We have two Mohits in the hall today. One is Mohit Saran, and other is Mohit Sharma also, I believe there. But the person I'm going to felicitate is Dr. Mohit Saran. Please come forward. Give him a big hand. He is one of the persons. Dr. JK will give a ring at any time, and Dr. Mohit Saran, Dr. Manchanda, Dr. Puneet Khanna, and Dheeraj will immediately come forward for any work. I'll request you all to keep blessing IPF, and we will try to remain up to your expectations always. Thank you very much.
Thank you so much, sir, for blessing all of us and the conference in general. Now we have Professor Hemchandra, sir, to deliver his greeting address.
Thank you very much, sir. A very good afternoon to all of ladies and gentlemen. Honorable Chief Justice Sri Ramana sir, the chief guest for today's function, the President of the Royal College of Physicians, Edinburgh, Professor Elder, and of course, the whole team accompanying him from all the way from the Edinburgh. The patron of the IPF, President of IPF, General Secretary, Dr. Kapoor, Dr. Khanna, Dr. Manchanda, dignitaries on dais, others, and of course, our invited guest, faculty members, delegates, media persons, and organizing committee. Indeed, it's my pleasure on behalf of my university, H.N. Bauguna Medical University, Dehradun, as a Vice Chancellor, representing this auspicious occasion in regards to the academics in the field of the medical sciences, and extend my best wishes on behalf of my university and myself, the whole team of the IPF for having organized such a program and invited us for the first time, the Honorable former Chief Justice, to whom we could see for the first time, and also, thank you very much, sir, and also the President of the Royal College of the Physicians from the Edinburgh. Thank you very much for your appearance in this particular forum, sir. And we are highly delighted. In fact, I came into the contact with the IPF General Secretary, Dr. R.K. Sharma, our dynamic figure, for the first time when I desired to be a member of the Fellow of Royal College of the Physicians. And once I came into the context, personally, in fact, in beginning, and then later on joined gradually the whole team of the IPF, and then I thought, there are such institutions in our country, though they are not directly connected to the medical college, those who are really the medical teaching institution, but I think not less than the teaching institution which imparted by the teaching institution by so-called what we call imparting the MD, MS or the MBBS degrees. The whole team is so much dedicated in the academics, I will tell you. For the first time I came to the contact. So I decided on behalf of the university that let the university be a institutional member of this particular renowned IPF. And really I went through my all academics councils, that what we say the academic council and the executive council. So as the Vice Chancellor today, I may not be tomorrow, day after tomorrow, or in due course of time after having completed my tenure, and my association and the university association will remain forever with the IPF for there. And I assure on behalf of the university, sir, that any other type of the assistance, especially we signed the MOU and exchange of the academics, any type of the programs. Since then, I am very thankful, grateful to the IPF that always they include our name in that wherever and whenever they are going to organize such a program. By heart, we are always together and will remain them. So on behalf, again at the end, I really congratulate and extend the best wishes to the IPF for a nice success, and nice to see all the team from the Royal College of the Physicians, from the Edinburgh, sir. And I, on behalf of the university, invite all of you to be in Dehradun, to come sometime, be with us also. Thank you very much, sir. Thank you.
Thank you so much, sir. You've been so gracious. Now I invite Professor Andrew Elder to give his address.
Honourable Chief Justice, our patron Professor Sharma, our chief guest, fellows, colleagues and friends. Good afternoon to you all. As you've heard, my name is Andrew Elder. I'm a geriatrician and I'm the president of the Royal College of Physicians of Edinburgh. And it's my real pleasure and honour to visit with you and speak in this inauguration ceremony for the 5th
Innovative Physicians Forum sessions of 2022. On behalf of myself and my visiting colleagues, thank you for the invitation to participate, and thank you for the warmth of your welcome. The Royal College of Physicians of Edinburgh sets great store on two things that are central to our gathering this weekend. The first is education and lifelong learning. Our college's educational model is a collaborative and inclusive one, based on the idea that whoever you are and wherever you work in the world, we all can learn from each other. The doctor in India can learn from the doctor in the UK, the doctor in the UK from the doctor in India. The teaching hospital consultant can learn from the rural polyclinic doctor, the rural polyclinic doctor from the teaching hospital doctor. The geriatrician can learn from the cardiologist, and the cardiologist can learn from the geriatrician. We can all learn from each other, and as I say, that's central to our college's educational belief. And secondly, our college also sets great importance on something that this conference crystallises, and that's connections. Connections that cross times, geographies and languages. Connections based on fellowship, collegiality and friendship. I think we've all learned over the pandemic that online communication for educational and clinical purposes does work, and indeed we couldn't really have managed without it. But we've also seen the limitations of that technology, because there's nothing quite like being in the presence of our patients and being in the presence of our colleagues. There's nothing like meeting in person. And this conference provides a welcome opportunity to do just that, to revisit and strengthen existing connections, to form new ones, and to continue a tradition of face-to-face meetings between our two medical communities that has existed for many, many years. I want to say some specific words of thanks. First, I know that many people will have put a lot of work into organising this meeting. We run a lot of meetings in our own college in Edinburgh. So I should say, I think, particular thanks to Professor O.P. Sharma as patron, Dr. Meena Chabra, the organising chairman, Dr. Puneet Khanna, scientific chairman, for their efforts. And our own college's involvement in this would not have happened without the work of Professor Jugal Sharma, who, as well as being the organising secretary, is our regional advisor for the college for North and Central regions of India. And I'd like to thank you personally, Jugal, for all your work for this meeting and for all your other work in association with our college. Secondly, I want to thank my colleagues from the Royal College of Physicians of Edinburgh who've travelled here to be with you this weekend. Our college was founded in 1681, which is quite a long time ago, and we stand now, over 300 years later, as a modern 21st century charity dedicated to the improvements of standards of patient care. But we're no longer confined to the city of Edinburgh, or indeed to Scotland, for we have over 15,000 fellows and members in over 100 countries, and we're truly a global organisation. But although we were founded in 1681, it took until 1929 for us to have our first female fellow. She was called Dr. Isabella Pringle. But now, in 2022, equality, diversity and inclusivity are golden threads that run through the entire fabric of our work. The Royal College of Physicians of Edinburgh wishes all colleagues, whatever their gender, ethnicity or religion, to feel welcome and valued in our college. And I hope that fact is made plain in the diversity of the faculty that accompany me here to this meeting. And finally, may I thank you all. The pandemic of COVID-19 has stressed the entire world and its peoples. Few have passed entirely unaffected. The medical profession and most fellows and members of the college have been at the forefront. There have been many challenges for the medical profession through the pandemic, and I think we should all be proud of the response of the medical community. In speaking to colleagues around the world, common themes emerge. Themes of personal sacrifice and commitment, of enhanced multi-specialty and multi-professional team working, of flexibility and innovation in healthcare delivery, and of an unwavering commitment to the highest standards of care for all patients. So I thank you for that, but I also recognise that that effort has taken its toll. The well-being of many doctors and other healthcare workers has been affected, and indeed lives have been lost. So I think we should remember that as we gather here today for our celebratory meeting, and I thank you again for your own commitment to patient care through these difficult times. So in conclusion, I'd thank you once again for your warm welcome, and with such a superb programme of talks, I've no doubt that these 5th IPF sessions will be a great success. We are deeply proud of our college's long and enduring relationship with the medical community of India. Long may that flourish. Thank you very much.
Thank you so much indeed. Now I invite our guest of honor, Dr. M.L. Swarnkar sir, to give his address.
Good afternoon. Honorable former Chief Justice of India, Sri N.V. Ramanna ji, the chief guest of today's function, my alma maters, Dr. Professor O.P. Sharma and Professor J.K. Sharma ji, Professor Andrew Elder from Physician, President of the Royal College of Physicians of Edinburgh, distinguished dignitaries on the dais, my institutional, our IPF institutional partner, Professor Hemchandra of the Himati Nandan Bahuguna University, Uttarakhand, my institution's university colleagues here, our respected Vice Chancellor Dr. Sudhir Sachdeva, I can see Professor of General Medicine Dr. Puneet Rijwani, Dr. Anchan, Dr. Sarna, and many postgraduate residents also of Mahatma Gandhi University of Medical Sciences and Technologies, and distinguished delegates. It is a matter of privilege and pride that such a beautiful conference, academically oriented conference, has been organized by the Innovative Physicians Forum of India. I am listening to the talks since morning, and I can very strongly say, I was listening to the talk on the tachycardia, on the steroids, on the diabetes, and the contents, scientific contents are extremely beautiful and very enlightening and very enriching. I hope this trend will continue in coming year as the commitment of Dr. Jugal Sharma and Dr. O.P. Sharma and Dr. Manchanda and other friends are there, who are the core strength, Dr. Meena Chhavda, who are the core strength of this APF forum. The theme of this fifth conference is the holistic approach to the medicine. What I can say in brief is that always go for the evidence-based medicine if you are suffering from any ailment. This is my personal view for last 40-45 years of experience. You can have some lifestyle changes. You need to have lifestyle changes. It is necessary. Everything in moderation is necessary. Having the regular exercise, having the good quality nutrition, good food, good sleep, proper sleep, these are necessary things. But don't go for something abrupt change from the modern medicine to the some other alternative medicines without knowing the total facts.
So holistic approach in the sense of doing the lifestyle changes, inculcating the habits of the spirituality into the science, they are wonderful things. They reduces the stress. We know that the genetics is one of the important cause coming up, or we are knowing now. We also know that the stress are responsible for many psychological and physical problems. So we need to control them, and the spirituality or doing meditation, doing yogas, doing some social work which improves the lifestyles of the poor and down to people is very good and very satisfying. So it reduces the stress level, but we do not know so many things. When we got independence, our life expectancy in India was around 30 to 33 years age. Now it is almost 60, 65. Why? It is because of the improvement in the quality of the medical care. It is the modern medicine which has led to the improvement in the life expectancy. So this is what, without any bias, I say that holistic approach has to be modern medicine and our root values which we enriches in our country. And I really thank Dr. J.K. Sharma ji, Dr. Ipf Sharma ji for inviting me and giving me opportunity to share some of my views. So thank you very much, sir. And we are really glad that we will be hosting this 6th conference next year in Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. I invite you all to Rajasthan, and Jaipur is a beautiful city. I mean, the beautiful state and beautiful city, and you will enjoy the Rajasthan hospitality. Thank you very much.
I would like to invite Professor Sudhir Sasdeo to formally get the first flyer released for the IPF Medicon 2023 by the dignitaries. So the release of the first flyer for the conference of IPF Medicon 2023, I invite Dr. Sudhir to please come here.
So here is the invite. Here is the inauguration of this invitation card, this poster for the IPF Medicon 2023, which is going to be held at Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. I, being the Vice Chancellor of the university, invite all the delegates who are here, all the friends who are not here, but their friends as a delegate sitting here, kindly invite everybody. We welcome you all, and I assure you that you will get the academic fiesta as well as the best welcome. I invite you all. Thank you very much. All the dignitaries, Honorable Ramanna Sahab, and guest of honor Dr. Swarnakarji, and all other eminent authorities standing on this stage. Once again, I welcome you all and invite you all to Mahatma Gandhi University of Medical Sciences and Technology. Come and see what university is doing and what we are. Thank you very much. Thank you.
The young man who is going to take care of all of you is Dr. Puneet Rijwani. Give him a big hand.
Professor Puneet Rijwani is the professor and head department of general medicine, and he is with the university since last 22 years. Thank you. Thank you very much.
So, thank you very much. And now I take the privilege to invite Honorable Justice N.V. Ramana sir, our chief guest for today's function, to give his inaugural speech. Sir.
Professor M.L. Swaranka, Professor M.V. Jolly, Professor O.P. Sharma, Dr. Meena Chabra, Professor Andrew Elder, Professor J.K. Sharma, Dr. Puneet Khanna, Dr. Sudhir Sachdeva, Dr. Vasanta Kumar, Dr. A.K. Manchandani, other members of the organizing committee, executive committee, and office bearers and members of the IPF, and distinguished doctors, professionals who are going to illuminate the proceedings by their speeches. Friends from media, ladies and gentlemen, good afternoon. It gives me immense pleasure to be speaking before this August gathering on the occasion of the 5th Annual Conference of the Indian Physicians Forum. Indian Physician Forum focuses on ensuring the dissemination of the newest and most contemporary medical information. In its attempt to improve access to the highest standards in medical education, research and practice, it provides much needed space to intellectuals, academicians, researchers and doctors. I am extremely happy that an organization such as the IPF has emerged in India and has been successfully organizing such meaningful conclaves year after year. It is indeed a matter of pride that prestigious bodies like the Royal College of Physicians, Edinburgh, have come to associate themselves with a noble mission. I thank on behalf of Indian doctors, the doctors from Royal College of Physicians, for their coming and sharing their knowledge. I congratulate all the office bearers and members of the association and wish you all the best in your endeavors to help mankind. The annual conference is aimed towards meeting the objects of the forum. Eminent participants are coming to illuminate this gathering on a number of updates related to a variety of topics, ranging from the practice of internal medicine and allied specialties to lectures on scientific writing and cyber security. You all will immensely benefit from your participation in this event. I must confess, I was a little aback when I was invited by my friend and personal doctor, physician, Dr. Vasanta Kumar, to be the chief guest of this inaugural function of this event. The reason, even though I could not refuse this invitation from the doctors community, Dr. Vasanta Kumar's request was actively followed by the organizing secretary, Dr. Jugal Kishore Sharma. But as the former Chief Justice of India, I am still a bit confused as to what I could discuss with you at such an event. You see, if all are doctors except me, I am the patient. It would be inappropriate for me to lecture you about the specifics of medical practice. I leave that to the subject experts who are going to address the diverse sessions in this conference. However, I would like to say just a few words about the theme of the conference, that is holistic approach to practice of medicine, need of the hour. The theme emphasizes on taking a comprehensive view on everything that we humans deal with,
In the global village that we are living in, no area can thrive in isolation. We grow up in times when every family would consult a particular doctor who would be through with the medical history of the entire family. In other words, the family doctor would have a complete picture of the health status of the family and would adopt a holistic approach in deciding the course of treatment. Unfortunately, with the entry of the corporate sector, such healthy traditions are vanishing. Being a diabetic for more than 30 years, with other medical issues linked to the stress of being a judge for 22 years, I am lucky to have been graced with the assistance of some of the best doctors in the country, including Dr. Vasant Kumar, who I now count as my personal friends. They have always made it extremely easy for me to talk to them about the issues which I had. The fact that my eldest daughter is also a doctor, a radiologist, meant that I could keep in touch with the latest medical information. I have also occasionally read articles from Lancet and New England Journal of Medicine, particularly those linked to my own health reasons and problems. I have therefore, through my personal medical journey, keenly observed the changing medical landscape. Medicine, like every other field, including the law, is forever evolving and changing. The advancement in technology has really been a boon for all fields, including the medical field. But unlike other fields, the advances in medicine have the greatest relevance for society and humanity as a whole. Research in the field of medicine is undoubtedly the most significant contributor for human development. Most recently, the global effort undertaken by doctors, researchers, and scientists has helped to prevent the worst outcome of the COVID pandemic. Medical research and the task of disseminating new information is therefore absolutely vital, which is why I believe the task undertaken by the IPF and the work done by all the participants here is exceptional. It enables medical practitioners and researchers from across India to gain access to wealth of contemporary knowledge. However, such conferences are only the starting point. The activities undertaken after the conferences are also important. The first connects of the idea of the constant need of innovation. We must never be satisfied with the level of knowledge that we are at currently. This advice is not just for the researchers, academicians, and students, it also for the doctors. You will be applying theoretical knowledge in your practice. You must look to your professional activities with scientific temper. Doctors should play an active role in medical research rather than a passive role. Real innovation takes place only when everyone in the ecosystem works together. The second aspect I wish to talk about is communication, dissemination of information to the general public. A lot of misinformation about health and medicine is widespread and continuously receive coverage, not just on social media, but also on traditional sources of information, such as television and even newspapers. Communicating science is sorely needed in the world today. To counter the fake information propagated so aggressively, I request the organizers of this conference and the participants to take an active interest in spreading information. Such communication should be a variety of languages and not only just in English. It should be the simplest and clearest terms. I hope and wish that everyone here becomes an effective communicator so that society as a whole can benefit. I also have a request for all of you. We live in a society where there exists great income inequality. This consideration should also influence your research and analysis. In contemporary times, fulfilling the responsibility of a doctor has been becoming extremely difficult. Doctors are the focal point of the system. they are in direct contact with the public. In facing the public, they are forced to deal with some truly modern problems. The first is a shift in attitude of society. I was shocked to hear of all the threats and violence against medical professionals in India and across the world. It is unimaginable that this was taking place even during the pandemic, when they were risking their lives and working overtime. At the cost of their personal health and well-being, I took up the cause of protection of medical professionals in every possible manner on the judicial side, as well as through public interest. I can give an example when I am discussing with the doctors before I am coming here. I also expressed my views about the main problems of the violence or attack against doctors, particularly in India. I feel that the insufficient infrastructure and not available medicines, no proper technical support, no allocation of budget. These are the main reasons which the Indian doctors, particularly working in rural areas, is facing. The doctor is posted in a particular place without infrastructure, without medicine, without any help. The patients will come and ask the doctor to treat. They can only examine and say, this is the disease which you are having. They can't provide medicines. The patient is not in a position to accept that, and they start attacking the doctors. Who is responsible for this also has to be examined. In the presence of the health secretaries and the higher authorities of the government of India, I raised the issue. Again, I am raising this issue in this forum also. So this is the states and center need to take an active role in providing necessary protection and support for doctors, nurses, and paramedical staff. The second relates to something I had touched upon earlier, the widespread false information on social media and internet. Honestly, the internet caused grave difficulties for the medical practitioner. Now, anyone who has a mobile or a computer considers himself or herself a medical expert. On the basis of half-baked information, they draw their own conclusions and make it that much more difficult for you to give proper advice. Just because you can access a little information, it does not make you a full-fledged doctor. Just like being able to read some statute books and does not make you a lawyer or a judge. The sacrifices and the hard work put by a doctor from the day they enter college and throughout their practice is what makes them a medical professional. This needs to be understood by the large public. Despite the above, the fact that thousands of doctors continue to do their job without appreciation, without sufficient pay, with devotion to service, is a testament to their professional ethic. Vaidyo Narayano Hari is an apt phrase describing all of you gathered here. Your contribution to society will forever be remembered. Personally, I salute all of you. Before I take leave, I want to advise on two issues. One is the keeping the medical record properly. I just saw Dr. Meena's presentation about diabetes and the speech. She has expressed, and I am very glad that the main point, focal point, which I also traced, that keeping the electronic record. It is easy nowadays. Otherwise, you will be forced to pay huge amount of compensation under the Consumer Protection Act or criminal cases. Unfortunately, doctors are not lawyers where they can make a note of everything, but because of the change in the law and the system and the understanding of the issues, it is always better that we must record at least one or two sentences while you are treating a patient. Don't treat, even though you are treating free of cost, you are giving to your friend also an advice, it is always better that you must keep the record properly so to avoid further complications and litigation in future. I must share a thought repeatedly bothers me. I keep wondering why we in India, in spite of having the best of talent, are lagging behind when it comes to receiving global accolades such as the Nobel Prize. Maybe it has something to do with our approach to medical research rather than pursuing what interests the West and the pharma industry. It is high time we focus on prevention of diseases that affect a large number of people living in India in the developing world. Thank you to the organizers for giving me this opportunity to speak today. Let me wish all the participants and organizers great success for this conference. Thank you once again.
Thank you very much, sir. Now, I invite Professor M.V. Jali. Innovative Fusion Forum has decided to honor Dr. M.V. Jali with a Lifetime Achievement Award. Sir, please. Professor Jali was Medical Director and CEO and Chief Diabetologist of KLE's Dr. Prabhakar Kore Hospital, Professor of Diabetology, KLE University, JN Medical College, Director KLE's Diabetes Center. Sir, you are the Medical Director and CEO of KLE's Dr. Prabhakar Kore Hospital, Belgavi, Karnataka, and been a Professor of Diabetology and Chief Diabetologist since 2000. He is also the President of the National Diabetes Foundation, Belgavi, since 2000 and a past President of the Geriatric Society of India, New Delhi. Professor Jali received his advanced training in diabetes in 1998 at the prestigious Joslin Diabetes Center, Harvard Medical University, Boston, USA. In 2014, he was the principal investigator of the Tuberculosis Diabetes Bidirectional Study Group conducted by WHO Geneva, the World Diabetes Foundation, Union Paris, and the Ministry of Health, Government of India. Sir, you have received numerous accolades for your work in the field of diabetes and has received prestigious national and international awards. He was the recipient of the prestigious Dr. B.C. Roy Award from the Medical Council of India in the year 1981, Dr. R.V. Sathe National Award from the Diabetes Association of India in 1985, the Vidyasri Award of Dr. P.S. Shankar Pratishthan, Kalaburgi in 2016, Distinguished Award from the Influenza and Vaccine Advocacy Forum of India, New Delhi in 2016, and the Suvarna Karnataka Rajyotsava Award and Indian Red Cross State Award in 2017. Professor Jali was also awarded the Diabetes India 2016 Award at the 7th World Congress of Diabetes in New Delhi for being one of the best 40 centers in India for raising awareness of diabetes in India. He was bestowed with Lifetime Achievement Award at the All India Physicians Conference held in Belgavi in 2019 and honored by Karnataka government with the Karnataka Science and Technology Honorary Fellowship on August 1, 2022 at Bangalore. Dr. Jali's research interests include diabetes, geriatric care, epidemiological studies, clinical trials, research, and tertiary care hospital administration. He has authored and co-authored for national and international journals with more than 120 articles, abstracts, and book chapters in the field of diabetes and its complications. He has received the fellowship from Royal College of Physicians of London in 2016, Edinburgh in 2017, and Glasgow in 2018, and is an academic life member of Innovative Physicians Forum. The Innovative Physician Forum academic family feels proud and honored in presenting the Lifetime Achievement Award to Professor Dr. Mallikarjun V. Jali. And I now request the dignitaries on the dais to please honor Dr. M.V. Jali with a shawl. Thank you, sir. Now I request our chief guest, Honorable Justice N.V. Ramana, sir, to please honor our guest of honor, Professor Abel Swarnkar. And I request Dr. Sachdeva, Dr. Sudhir to please come. Professor Elder, you please also join. Dr. Meena. Now, I request our chief guest to please honor Professor Hemchandra ji and Dr. Andrew Elder. Now I invite Dr. Basant Kumar sir and Dr. K.C. Goswami sir, General Kalra sir and Dr. C.B. Sharma ji. Kindly come on the dais to honor our chief guest, Honorable Justice N.V. Ramana sir. And everybody on the dais please join. Thank you everyone. Now I invite Dr. A.K. Manchanda, my friend, to say a vote of thanks. Dr. Anil, please be brief.
Dear colleagues, the August gathering, this is my proud privilege to address the galaxy of people around. I pay my thanks to Chief Justice Mr. P.V. Ramana for accepting the honor of being Chief Guest here. Professor Swarnkar, who belongs to the same state, Jaipur, where I belong to, he is the guest of honor. Thanks, Professor Swarnkar, for accepting our being guest of honor here. Along with Professor Swarnkar, my friend, colleague, and childhood friend, Dr. Sudhir Sachdev, who is the Vice Chancellor of Mahatma Gandhi University. I also pay special thanks for being here and honoring this occasion. Our team of IPF, under our leadership of patronship of Professor O.P. Sharma, who needs special thanks, our chairperson Meena Chhabra, Secretary General Dr. J.K. Sharma, who is the guiding force behind all this happening of leaping forward of this IPF forum, Dr. Puneet Khanna, Dheeraj Khanna, Dr. Mohit Saran, and other team member of my Innovative Physicians Forum. They deserve a special thanks because they burn the midnight oil to make this occasion a success. Professor Hemchandra from Hemchand Bahugana University, and Dr. M.V. Jali from KLE Beligavi. They were the laureate of this occasion, who honored this this occasion. And these two universities, Mahatma Gandhi University and Hemwati Nandan Bahuguna, are our affiliated members of these two, our IPF organization. Special thanks to by foreigner dignitaries, Dr. David Mowley, Dr. David Skelly, Dr. Andrew Elder, who is the president of the Edinburgh, FRCP Edinburgh, Dr. Kathleen, and Professor Mark Stretchen, who took special pains to come over here and agree to be participant of this forum. And in last, all the faculties, delegates who made this occasion success. Without them, this field not could have gone success. Besides that, the logistic teamwork, my concept, and the other team colleagues of this organization, they also need special applause. And thanks a lot, all of you, and thanks a lot, Team IPF.
Well, thank you so much. So we all break for lunch. It'll be a shortened lunch. Back at 2:30, please. Thank you.